Hello once again. In this audio lecture, we're going to be discussing psychiatry for the USMLE Step 2CK exam. This is specifically my UWorld notes that I am going to be dictating. This covers everything that I was able to gather from UWorld, and it makes a pretty good review, especially if you're out on the road or in a situation where you're not able to be reading something and you still want to be studying. This is a good tool for that. So let's start her off. So psychiatry, we're going to start off with the assessment of decision-making capacity. So the assessment of decision-making capacity depends on the criteria and what the patient's task is. So if the criteria means that the person has to communicate a choice, that means that the patient's able to clearly indicate a preferred treatment option. That's the criteria for that decision-making capacity. If the patient understands a condition and the treatment options, that means that the patient understands the information provided. If the patient acknowledges having a condition and likely consequences of treatment options, including no treatment, that means that he appreciates the consequences behind that decision. And if a patient's able to weigh the risks and benefits and offers a reason for their decision, that's a rationale given for the decision. So all those are assessments of a good decision-making capacity. Next topic would be defense mechanisms. So key defense mechanisms are divided into immature defense mechanisms versus mature. The immature defense mechanisms include primitive and neurotic mechanisms, and they're the majority of the ones. So, for example, acting out means expressing unacceptable feelings through their action. Denial is behaving as if an aspect of reality doesn't exist. Displacement would be transferring someone's feelings to a more acceptable object. That's displacement. Intellectualization means using someone's intellect to avoid an uncomfortable feeling. Passive aggression means to avoid a conflict by expressing hostility covertly. Projection means attributing one's own feelings onto other, kind of like you're projecting your voice. I always have a problem remembering this one, but it's like projecting your voice in order for somebody to be heard. This is projection. You're projecting your own feelings onto others. Rationalization means justification of someone's behavior to avoid a difficult truth. There's reaction formation, which means responding in a manner opposite to one's actual feelings. Regression would be reverting to an earlier developmental stage. And then splitting would be seeing others as either all good or all bad. So all of those are immature defense mechanisms. The mature mechanisms, there's only two. There's sublimation and suppression. So they both start with the letter S. So sublimation means channeling someone's impulses into a socially acceptable behavior. The classic example there is someone who likes to start fires and becomes a firefighter. That is a sublimation. And then suppression would be putting unwanted feelings aside to cope with reality. You can tell those two are going to be more mature ways of dealing with an issue in life versus all the other ones are kind of a childish, very an immature way of dealing with things. So if he's just, that's a good way of categorizing him. Altruism is a mature defense mechanism in which a person manages unpleasant emotions through services to others. This service is going to provide gratification, unlike in reaction formation, in which a true sense of the internal pleasure is going to be lacking. So the neuroimaging in psychiatry disorders would be the following. So in autism, you'll have an increased volume, total brain volume. Obsessive compulsive disorder means that the abnormalities in the orbital cortex and the striatum. So obsessive compulsive disorder, the O in obsessive is the O in orbital cortex. Panic disorder is decreased volume of the amygdala. So the A in panic, you can remember it as the A in amygdala, but it also affects the left temporal lobe. Also, post-traumatic stress disorder means that you'll have a decreased volume in the hippocampal region, and then schizophrenia has enlargement of the cerebral ventricles. In clinical practice, there's structural neuroimagings like CTs or MRIs, and that's often done as part of a diagnostic workup for patients with new onset of psychoses to rule out any type of non-psychiatric disorders. So that's why you do a CT or MRI when you have a new diagnostic workup. You want to see if there's increase in brain volume, if there's any kind of abnormality in the cortex, in the amygdalas, and so on. Any type of cerebral ventricle enlargement. So routine neuroimaging is not indicated in patients with a known psychotic disorder. This is just done to evaluate first off to see if the diagnosis could be made through a CT. But once it's not, then you can just forget about doing any more neuroimaging. Functional neuroimaging techniques like a PET scan or a functional MRI and an MR spectroscopy are important research tools in psychiatry, and those are used to study neural activity and brain pathways involved in psychiatric disorders. However, they're not routinely used in clinical practice. And then we have selective mutism, which is a condition in which children have a fear of a situation that call for them to speak, like a school or social gathering, as well as social phobia. That's also called social anxiety disorder. It's often a comorbid condition in children suffering from selective mutism, with anxiety and avoidance commonly occurring. The DSM-5 criteria for selective mutism is going to be either consistent failure to speak in some specific situation, like at home or at school, but not others in which a person is expected to speak. So these are all, selective mutism is always an alternative to some type of autism spectrum. So be sure to differentiate these. So the other one would be a duration of at least 1 month. So mutism would be at least for 1 month. There's interference with educational or other expected achievement or social communication. It's not attributable to lack of knowledge or comfort with a spoken language. It's just them deciding to not speak. Other communication or autism spectrum disorder or psychosis do not account for the presentation. So that's what I was saying. In these cases, they only speak in specific situations, either at home or at school. But versus autism, they just won't speak at all if that's what they want to do. So it's not geared towards a specific situation or condition. So continuing on with attention deficit hyperactivity disorder, clinical features would be like inattentive or hyperactive impulse syndrome symptoms that last for more than 6 months. Inattentive symptoms would be difficulty focusing. They're very distractible, does not listen or follow instructions, very disorganized, forgetful, and loses and misplaces objects. Versus hyperactive impulsive symptoms would be as if they would be fidgety or unable to sit still. Like if they're driven by a motor is what it's an example would be. Hyper talkative, interrupts, blurts out answers. Symptoms would be severe if they present before age 12, and symptoms occur in at least 2 settings, either at home or at school, and cause functional impairment. There's subtypes that are predominantly inattentive, predominantly hyperactive or impulsive, or combined inattentive, impulsive. And then the treatment for ADHD would be stimulants like methylphenidate or other amphetamines. Also non-stimulants such as atomoxetine and alpha-2 adrenergic agonists, as well as behavioral therapy. Adverse effects of methylphenidate would be like nervousness, loss of appetite, nausea, abdominal pain, insomnia, and tachycardia. The loss of appetite is the one that's most commonly associated, and the nervousness. And there's also prolonged therapy has been shown to cause mild growth retardation with weight loss. Methylphenidate should not be used in children younger than 6 years old because of safety and efficacies within this age group. It just hasn't been evaluated. So the DSM-5 criteria for ADHD would be more than 6 inattentive or more than 6 hyperactive or impulsive symptoms for more than 6 months. There's several symptoms present before age 12, and symptoms do occur in at least 2 settings, either at home, school, or in peer relations. There can be functional impairment like social or academic impairment, and there's predominantly there's various subtypes. So you have predominantly inattentive, predominantly hyperactive, impulsive, or a combined inattentive, impulsive type. For inattention symptoms, there is no attention to detail in patients with ADHD. They make careless mistakes. There's difficulty focusing on things like games and tasks. Reading and lectures make it difficult. They don't appear to listen when you speak to them. They cannot follow instructions because of that, and they get sidetracked easily. They're unable to finish tasks. They have also difficulty organizing tasks such as disorganized work, poor time management, and they avoid tasks. You need to avoid tasks requiring sustained concentration for them. They can easily lose or misplace objects requiring to perform tasks like books, phones, keys. They can all misplace that. They're easily distracted by extraneous stimuli, and chores and appointments can then be forgetful to them. They also have hyperactivity or impulsivity symptoms. So characteristics would be they fidget a lot, they have difficulty staying seated, they run or climb inappropriately, they cannot perform activities quietly. They're physically active all the time, as if they're driven by some kind of motor that constantly working. They talk consistently and constantly, and they blurt out answers and complete other people's sentences. They also have difficulty awaiting someone's turn. So they were in a line or something, they have difficulty awaiting their turn, and they're constantly interrupting and intruding when others are also busy or speaking. So patients with ADHD are at higher risk of developing a conduct disorder in adolescence. And one of the vignettes do describe a patient who has ADHD, and they ask you what are they more likely going to develop, and it is conduct disorder when they reach adolescence. Now, conduct disorder by the DSM-5 is categorized by aggression towards other people and animals, destruction of property, serious violation of rules, deceitfulness, or theft. So aggression towards people and animals would be that they would initiate physical fights, they're bullies, they threaten, intimidate other people, they use weapons to cause serious harm to others. They can also be physically cruel to people, physically cruel to animals. They can steal while confronting a victim, and they can also force someone into a sexual activity. They can also cause destruction of property, such as setting fires. So watch out with pyromania in these differentials. Also, they can intentionally destroy properties of others. And they also have serious violation of rules. So they'll be running away overnight at least twice or once without returning for a lengthy period. Being truant from school, often starting before age 13, and they frequently are staying out at night despite parental prohibitions starting before age 13. So they really won't listen to their parents even at an early age and just do whatever they want to do. They frequently are lying to obtain goods for favors, and they break into cars or buildings and steal items of non-trivial value without confronting a victim. So this is diagnosed at least when they have 3 behaviors and they have been present within the last year or within the past 12 months, with at least 1 present in the past 6 months. So they can also be at risk of developing antisocial personality disorder as adults. And the diagnosis of antisocial is not given to patients less than 18 years of age. Before they're 18 years old, antisocial personality disorder is basically conduct disorder. Next is kleptomania. Clinical features would be rare impulsive control disorders of typical onset in adolescence. The repetitive failures to resist impulsiveness to steal. Stealing objects have little value. They just basically want to steal things for the purpose of just stealing. They can also be, a differential diagnosis would be shoplifting. But in this case, shoplifting would be theft for a personal gain. In kleptomania, there is no personal gain. In antisocial personality disorder, it's a general pattern of antisocial behavior, whereas in kleptomania, there could be a completely fine, normal individual. They just require themselves to steal for some reason. Bipolar disorder would be another differential. With a manic episode, such as a person who has impulsivity or an impaired judgment, as well as other psychotic disorders like stealing in response to delusions or hallucinations, like saying, oh, the devil made me steal this or break into this place to steal that. With kleptomania, there is no psychotic behavior or deceitfulness behind that. So kleptomania can be treated with psychotherapy as well as medications. Psychotherapy is going to involve cognitive behavioral therapy orientation, focusing on techniques to resist and manage urges and anxiety, as well as medications that have been used for this would include SSRIs, opioid antagonists, lithium, and anticonvulsives. Pyromania is the next topic. The DSM-5 describes this as a deliberate fire setting on more than one occasion with tension and arousal prior to the act. There's fascination with fires and its consequences. There's a pleasure behind setting fires and relief when setting or witnessing a fire. There's no external gain. There's no revenge or political motivation. There's nothing of that sort. It's just the primal urge, I would say, to just set a fire. And it's not better explained by conduct disorder, manic episodes, psychosis, antisocial personality disorder, impaired judgment, none of that. They just like setting fires. Okay, Tourette's disorder is the next topic. The DSM-5 states that this is both multiple motor and one or more vocal tics involved. It's not necessarily concurrent, but it does happen more than once a year. The motor findings would be facial grimacing, facial blinking, head or neck jerking with shoulder shrugging. There could be tongue protrusion and sniffing. Vocal tics would be like grunts or snorting, throat clearing, barking, yelling, or yelling obscenities, also known as coprolalia. The onset of this happens before age 18. And the treatments for Tourette's would be antipsychotics, which is a very known answer to a question. Alpha adrenergic agonists like clonidine and guaifenesin, and behavioral therapies that can habit reverse themselves. So it's in forms of training themselves to not do this or suppress these tics. If the tics occur many times a day, frequently in bouts, nearly every day or at regular intervals, the tics can wax and wane, but they must persist for more than a year after the initial onset, and they must occur before the age of 18 in order to be properly diagnosed. There's an exacerbation in stress and fatigue, and it's also relieved during sleep. Comorbid conditions, there could be an association with ADHD in 60% of patients, or an OCD with 27% of patients, and it can develop within 3 to 6 years after the tics first appear. It may peak in late adolescence or in early adulthood at a time when the tics are waning. And less common comorbid conditions include anxiety, depression, and impulse control disorders. Now, their management would be pharmacotherapy. If that's given, it interferes with social, academic, or occupational functioning. So it's based on older trials. First-generation antipsychotics like haloperidol, pimozidine. These are the only FDA-approved medications for Tourette's disorder. However, due to the side effects of first-generation antipsychotics and prolongation of the QTC interval, that's associated with pimozide. Second-generation antipsychotics would then be generally preferred. And among the second-generation's antipsychotics, you have your risperidone, which is going to be the best one because that's the one that's been mostly studied. All right, so next topic is autism spectrum disorders. So some of the features of autism spectrum is multiple or persistent deficits in social communication and interaction, and it's currently or by the history of involving either social, emotional reciprocity, nonverbal communicative behaviors, developing or maintaining and understanding relationships. There's a restricted or repetitive pattern of behavior currently or by a history of either repetitive motor movements, insistence on the sameness or inflexible adherence to routines, fixated on interests of abnormal intensity or focus. There's adverse responses to sensory input, and the onset is in early developmental period and may occur with or without any kind of language or intellectual impairment. Now, assessment and management of principles. The early diagnosis is better for early intervention. There can be comprehensive assessment, multimodal treatments such as speech treatment, behavioral therapy, and educational services provided, as well as adjunctive pharmacotherapy for psychiatric comorbidities. The second-generation antipsychotic like risperidone has been shown to improve the aggression seen in autism spectrum disorder patients, but after other therapies are done. It's not first line. The DSM-5 diagnosis of autism spectrum disorder encompasses high-functioning autisms, like previously known as Asperger's syndrome, or I believe it was just reintroduced recently, the diagnosis of Asperger's. So that would be a higher functioning autism spectrum disorder. There's also childhood disintegrative disorder and any pervasive developmental disorder not otherwise specified. Diagnosis is going to be based on the history and behavioral observations that we just talked about, and the physician should empathetically listen to the parent's concerns, and a complete comprehensive evaluation should be done before making any type of definitive diagnosis. This evaluation is going to include structured assessments of social, language, and intellectual development, in addition to hearing, vision, and genetic testing, such as Fragile X syndrome. All right, so sexual behavior in pre-adolescence. So what's normal, what's abnormal? So in a toddler, what's normal is exploring their own or others' genitals, movements of masturbatory movements, undressing themselves or undressing others. That's completely normal in a toddler. In school age children, there's increased interest for sexual words and play. There's asking questions about sex and reproduction, as well as masturbatory movements that can become more sophisticated. Now, abnormal sexual behaviors in pre-adolescence would be repeated objects of insertions into the vagina or anus, sex play involving the genital, oral, or anal region or contact, any use of force, threats, or bribes, and age-inappropriate sexual knowledge. That is all abnormal. If you see that, that is then going to be considered grounds for child abuse. Next would be psychotic disorders. So the DSM-5 has certain criterias of the differential diagnosis of psychotic disorders. There's several. So brief psychotic disorders, schizophreniform, schizophrenia, schizoaffective, and delusional disorders. So brief psychotic disorders means that you will have psychotic symptoms that are more than a day but less than a month. They're sudden in onset, and they have full return to function after the month is over. So that's a brief psychotic disorder. Versus schizophrenia is at least 6 months, and that includes at least 1 month of active symptoms and can include prodromal or residual periods, and that requires functional decline. So at least 6 months is schizophrenia versus psychotic disorders that last less than a month is brief psychotic disorders. But what if you have a period that's between 1 month to 6 months? That's called schizophreniform disorders. So if it lasts less than 6 months, but more than a month, you're in the schizophreniform category. And those are the same symptoms as schizophrenia, just with a shorter time period. And because it's a shorter time period, there is no functional decline required to make the diagnosis of schizophrenia. Also, you have schizoaffective disorder, which is basically schizophrenia with mood episodes, which is an active phase of schizophrenia with at least 2-week lifetime histories of delusions or hallucinations in the absence of prominent mood symptoms. So you'll have mood with schizophrenia. It's the best way of describing that. So they'll present you as somebody who has signs and symptoms of maybe mania or major depressive disorder, and then at the same time they'll have psychotic episodes, like they'll see things or hear voices. Okay, delusional disorder would be more than one delusion in more than 1 month with no other psychotic symptom. They're actually normal functioning apart from direct impaction of the delusions. So prior to the diagnosis, it would be appropriate to rule out any type of substance-induced psychosis or a psychosis that's secondary to a general medical condition, because in that case, it would be kind of easy to misdiagnose someone with a brief psychotic disorder or a schizophreniform disorder if in fact they are just under the influence of some kind of substance-induced psychosis. So some of the symptoms of schizophrenia include the presence of either 2 or more of the following. So they can have delusions, hallucinations, disorganized speech, frequent derailment of or incoherence. They can be grossly disorganized or catatonic behavior involved with negative symptoms affecting like a flat effect or asociality, so somebody who doesn't want to be a part of society, or alogia. Now, schizoaffective disorder is basically, like we said, it's major depressive disorder or a manic episode with symptoms of schizophrenia. So some type of mood disorder with schizophrenia. There is a lifetime history of delusions or hallucinations for more than 2 weeks in the absence of major depressive or manic episodes. The mood symptoms are present for the majority of the illness, and it's not due to a substance or any other medical condition. So again, it's very important to distinguish substance abuse versus schizoaffective or other types of psychotic disorders. The differential diagnosis for schizoaffective disorder would be like major depressive disorder or bipolar disorder, like we mentioned earlier, with psychotic features. And that can occur exclusively during those mood episodes, as well as schizophrenia would be the mood symptoms present for relatively brief periods. Then you have your delusional disorder, and clinical features of delusional disorder would be more than one delusion for more than 1 month. Other psychotic symptoms can be absent and not prominent. There could be ability to function apart from a delusion, and that's a behavior that's not obviously bizarre or odd. Subtypes of delusional disorders would be erotomanic disorders, grandiose disorders, jealousy can be a delusional disorder, as well as persecutory and somatic symptoms can be delusional as well. Differential diagnoses for delusional disorder could be schizophrenia. Other psychotic symptoms can present, like hallucinations, disorganization, negative symptoms, and they can have a greater functional impairment. As well as another differential would be personality disorders, like pervasive patterns of suspiciousness, such as in patients that have paranoia or narcissism, showing grandiosity, or odd beliefs, like schizotypal patients, but no clear delusions. And the treatment for delusional disorder would be, again, antipsychotics, or cognitive behavioral therapy, or a combination of both is always the correct answer. There's also a classification of psychotic disorders called shared psychotic disorders, which is a very rare form of delusional disorder. Some delusions are present in individuals who share a close relationship. So this is very strange. If a person is completely normal, yet they're very close, let's say a husband or a wife or a sister or a brother, and they share the same relationship, and one of them has psychotic disorders, that disorder can actually spill onto the other person who was normally not supposed to have them, but because of that close relationship, they now have a form of delusional psychotic disorder, and that's called a shared psychotic disorder. That's the same delusion is present in the individuals who share the close relationship. Like we mentioned, it's usually the dominant individual in the pair that becomes delusional and transfers their delusions onto the second one. The management in these cases is most are appropriate courses. First of all, is to separate them. You basically break the chain of reinforcing each other's beliefs. But usually the dominant one requires psychiatric treatments. Sometimes they'll require inpatient treatments, whereas the other person will require treatment only in some cases. Like first you want to assess the other one by separating the two. And what are some of the indications for hospitalization? Would be the inability to function or obtain any type of outpatient treatment on their own, or if they're being a threat to themselves or others. And that just doesn't fall under this category. That's basically a generalized rule for indications of hospitalization. If you cannot function or obtain any type of treatment on your own as an outpatient, or if you're seen as a threat to yourself as to others, that's an indication for hospitalization. If both patients require the inpatient treatment, preferably you want to admit them into different units. Remember, separate the pairs. And if psychotic disorders are confirmed, then an antipsychotic and a cognitive behavioral therapy in combination is recommended. Now, the next topic is secondary causes of psychosis in children and adolescents. So it could be either due to medical disorders like CNS injury or dysfunction, trauma, space-occupying lesions, infections, stroke, epilepsy, cerebral hypoxia. Could also be due to metabolic or electrolyte disturbances such as urea cycle disorders, acute intermittent porphyrias, Wilson's disease, renal failure, liver failure, hypoglycemia, or any kind of electrolyte disorders like sodium, calcium, or magnesium. And then systemic disorders such as systemic lupus and thyroiditis as well. Also, hallucinogens like PCP, LSD, and ketamine, marijuana, sympathomimetics such as cocaine or amphetamines, and alcohol withdrawal. And the new one is bath salts. Those are all illicit substance use causes of psychosis in children and adolescents. And then finally, medications that can cause this would be intoxication with anticholinergics like diphenhydramine, scopolamine, serotonin syndrome, amoxicillin, erythromycin, clarithromycin can cause it, anticonvulsants steroids, and INH. And actually, if you withdraw from either baclofen or benzodiazepines, it can cause a psychosis. So how would you go ahead and manage them? Pharmacological management and treatment would be second-generation antipsychotics are always good. Risperidone, olanzapine, quetiapine, aripiprazole, ziprasidone, and paliperidone. Also, first-generation antipsychotics can be used, but they're obviously not preferred due to high risks of extrapyramidal side effects like tardive dyskinesia. And benzodiazepines can be added to the treatment so that you can treat any kind of agitation involved. Also, special populations like chronic noncompliance populations, you want to consider long-acting injectables in these patients, as well as if they've had any type of treatment resistance, such as they've tried 2 trials of medications and it failed. You want to consider in those cases clozapine. So clozapine's always been the answer to when haloperidol isn't working, or any type of first generation isn't working. You want to do the second line, it would be clozapine. So although antipsychotic medications is the primary treatment for schizophrenia, integrating both psychosocial interventions into a broader treatment program can improve the outcomes. Family counseling and psychoeducation have proven to be high-yield interventions in schizophrenia. For example, educating the patient's father about symptoms of schizophrenia, her social isolation, and declining grades are not laziness, and it can help reduce family stress. But that's reduce, not produce, family stress. Patients with schizophrenia who have critical, hostile, or over-involved family members, such as higher risk relapse, while if they're in the home atmosphere, if they're stable and the family stressors are kept to a minimum, you want to decrease the risk of that decreases the risk of relapse. So that is another test question where they ask, what would you want to recommend to the family? And it would be to stop arguing, have a peaceful home environment, keep family stress to a minimum. Antipsychotics, such as long-acting injectables, you want to administer every 2 to 4 weeks. Both first-generation and second-generation antipsychotics can be long-acting. So first generations are your haloperidol and your flufenazine. Second generations, we said earlier, like risperidone and paliperidone, olanzapine, and aripiprazole. These are available as long-acting injectables. And then suitable candidates would be unstable patients who, let's say, live at home, have poor social support systems, poor insight, frequent medication non-compliance, or patients who have had a good response to oral medication. All right. So what are some of the antipsychotic medication effects in the dopamine pathways? And so we're going to distinguish this into mesolimbic pathway, the nigrostriatal pathway, and the tuberoinfundibular pathway. So let's say for the mesolimbic pathway, antipsychotics have a higher efficacy in the mesolimbic pathway, whereas in the nigrostriatal pathway would be extrapyramidal symptoms like acute dystonia and akathisia and Parkinsonism. And then you have your tuberoinfundibular pathway, which can cause hyperprolactinemia. So mesolimbic would give you the efficacy of antipsychotics. The nigrostriatal would be the extrapyramidal symptoms, and the tuberoinfundibular will give you hyperprolactinemia. So you can get things like amenorrhea, gynecomastia, galactorrhea, decrease in libido resulting from an increase in prolactin. That's more common with the high-potency first-generation antipsychotics like haloperidol and flufenazine. And then second-generation antipsychotics like paliperidone, which is a metabolite of risperidone, and risperidone as well, can cause those side effects. prolactinomas can cause a very high prolactin levels. So you're looking at prolactin levels of more than 200 nanograms, whereas medication-related hyperprolactinemia is typically 25 to 100 nanograms with levels that seldom raise above 200. So some of these antihypertensives are associated with hyperprolactinemia, and those include risperidone, alpha-methyl-dopa, and verapamil. Okay, so moving on, we have antipsychotic extrapyramidal effects. So you have your extrapyramidal symptoms and their treatments. So for acute dystonia, this happens between 4 hours to 4 days. These are sudden, sustained contractions of the neck, mouth, tongue, and eye muscles. Treatment would be benzotropine or diphenhydramine for acute dystonia. Akathisia can happen at any time. Akathisia is subjective restlessness or an inability to stand still or sit still. And you treat akathisia with beta blockers like propranolol or benzodiazepines like lorazepam. Parkinsonism occurs 4 days to 4 months afterwards, after an antipsychotic is given, and these usually have gradual onsets of tremors, rigidity, and bradykinesia, which is slow movement. And some of these, and the way you would treat that would be with benztropine or amantadine. And then you have tardive dyskinesia, which occurs later on at 1 to 6 months of use. And these are gradual. This happens as a gradual onset after a prolonged therapy that usually lasts more than 6 months. Dyskinesia of the mouth, dyskinesia of the face, the trunk, and the extremities. And there's no definitive treatment, unfortunately, but clozapine can help with tardive dyskinesia. So types of dyskinesia, you have oral and facial dyskinesia, limb, neck and trunk, and respiratory dyskinesia. So the oral and facial are going to be your tongue protrusions, tongue twisting, lip smacking, lip pouting and puckering, retraction of the corners of the mouth and chewing movements. If the limbs are affected, you'll see limb twisting and spreading, piano playing finger movements and foot tapping, as well as dystonic extension of the toes. Neck and trunk, you'll see torticollis, shoulder shrugging, shoulder shrugging, rocking and swaying, rotary hip movements, and for respiratory symptoms, you'll see grunting noises. So extrapyramidal side effects are more common, again, with first-generation antipsychotics compared to the second-generation ones. Out of the second-generation antipsychotics, risperidone is going to be the one that's most likely going to cause the extrapyramidal symptoms, so remember that. And that's going to be obviously at a higher dose. And if the dose reduction is not even feasible with these patients, then you would want to give medication associated with whatever it is that they're suffering from that we've listed. Moving on, we have our next topic is neuroleptic malignant syndrome, and this is a highly tested question. So signs and symptoms would be sometimes you'll have severe fever, so you're looking at over 40 degrees Celsius, and that can develop within 1 to 3 days, associated with delirium often as its first manifestation. So high fever, you can have mental status changes, muscle rigidity, autonomic instability, tachyarrhythmias and dysarrhythmias, labile blood pressure. So rhabdomyolysis is followed by a myoglobinuria, which can cause acute renal failure, and that's a common complication. And as well as leukocytosis. Also tachypnea and diaphoresis. Those are all signs and symptoms of neuroleptic malignant syndrome. Remember the rhabdomyolysis, that's a big one. Precipitating factors would be antipsychotics, typical or atypical. Remember risperidone, if it's the atypical one, is the one that's going to cause it. And clozapine is going to be your go-to drug for that treatment. Antiemetics like promethazine and metoclopramide, but that's associated with meds that block dopamine transmission, and that can occur at any time after treatment.
Anti-Parkinson drugs such as dopamine agonists and medication withdrawal can cause this, and infections and surgeries. And the way you would treat it is to first stop the neuroleptic or restart dopamine agents. If they've done the withdrawal, you want to restart them. Or if they're on a medication, you want to stop the neuroleptic. Supportive care like hydration and cooling if they're having the fever. So antipyretics, alkaline, the diuresis in cases of rhabdomyolysis. And also the big ones here are dantrolene and bromocriptine and amantadine. So you can give either one of those three. Dantrolene, bromocriptine, or amantadine will treat neuroleptic malignant syndrome. And you want to monitor these patients in the ICU. So if they ask you typical psychotic patient that's under medical management with an antipsychotic, and they present to you with a fever, mental status changes, rigidity, and such, and then they ask you, where would you want to monitor these patients in? Do you want to discharge them home after they're being treated and everything is fine? The answer is no. You want to take them into the ICU. So what's the difference between neuroleptic malignant syndrome and serotonin syndrome is that in serotonin syndrome, that begins with vomiting, diarrhea, restlessness, and autonomic instability. And that's characterized by neuromuscular irritability, but not rigidity. So they'll have tremors and hyperreflexia and myoclonus, but they won't have muscle rigidity. Fever isn't really as high, even though it may be present. They'll give you a patient that's is febrile, so you'll see 101, maybe 102 as their fever. But here with these patients, they're suffering fevers more than 104, and also waiting 2 weeks between the discontinuation of an MAOI like phenelzine and the start of a serotogenic antidepressant like citalopram is deemed sufficient enough to avoid the risk of developing serotonin syndrome. So again, neuroleptic malignant syndrome, just remember it causes sweating, tachypnea, hypertension, tachycardia. You can have dysarrhythmia, muscle rigidity is the big one, fever, and altered mental status. So what are going on to the next topic? What are some of the metabolic effects of second-generation antipsychotics? So we know what first generations can do. What do second generations do? And one of them would be metabolic syndrome, like weight gain, dyslipidemia, hyperglycemia, including new onset of diabetes. The highest risk drugs that can cause these metabolic effects would be clozapine and olanzapine. Remember, olanzapine causes weight gain. The O, remember the O. Think of a big O as a big body in a person, a big round belly or something. That's olanzapine, and that is associated with weight gain. And monitoring guidelines would be a baseline and regular follow-ups such as body mass index, because these drugs cause weight gain, fasting glucose and lipids, blood pressure, and waist circumference. And the BMI is measured monthly. The rest is measured at baseline, then 3 months, and then annually. The earlier and the more frequent the monitoring needed in those with diabetes or those who have gained more than 50% of their initial weight gain. So you just want to closely monitor them if they are gaining weight. Olanzapine is a serotonin and dopamine blocker, but it also has affinity for the histamine receptors, alpha-1 adrenergic receptors, and muscarinic receptors. Olanzapine's most common side effect is going to be weight gain and sedation, like we said. The weight gain is due to the antagonism of histamine 1 and serotonin receptors, and the sedation is due to the blocking of the histamine receptors. Next is clozapine treatment guidelines. So we said earlier that the indications for clozapine would be for a treatment-resistant schizophrenia. So if they're resistant to some type of treatment, the go-to drug next in line would be clozapine. And in schizophrenia associated with suicidality, you also want to give clozapine. So if they're suicidal, clozapine is a good treatment and an indication to give. Adverse effects would be agranulocytosis. So you'll see a very low white blood cell count, and all the granulocytes would be low. Seizures, myocarditis, metabolic syndrome, as well as ileuses and hypotension can all be adverse effects of clozapine. So adverse effects, so with the exception of clozapine, no antipsychotic is superior to an other. It's least likely cause of extrapyramidal side effects, and it hasn't been shown to cause tardive dyskinesia. So that's why it can be a treatment for tardive dyskinesia, because it's not necessarily treating the tardive dyskinesia, but it can it just hasn't been shown to cause tardive dyskinesia. Okay, also clozapine is associated with treatment resistance. So any poor response to at least 2 antipsychotic trials will require regular monitoring of the white blood cell counts as well, because of the agranulocytosis, and absolute neutrophil counts due to risk of leukopenia and neutropenia, as well as the agranulocytosis, which we mentioned. Also, weekly blood counts should be done within the first 6 months of treatment to look out for that. So just remember that about clozapine. What else? One of my professors said that clozapine sounds like a clown. Clownapine, or whatever. And clowns are kind of weird and wacky. So clozapine can cause seizures. So maybe because it causes seizures and makes you look kind of wacky when you're having a seizure, that's like a clown, clozapine. Maybe that'll help you. It did help me, so why not? Wacky little things like that help sometimes. Next would be aripiprazole. That's another second-generation antipsychotic. Is both antagonist and partial agonist of the dopamine D2 receptors, and that's less likely to cause hyperprolactinemia. So if you're asked, most likely you'll be asked for aripiprazole. The only question would be, this patient has hyperprolactinemia as a side effect. What medication would you like to switch them to? And it would be aripiprazole. Ziprasidone is associated with QT prolongation at higher doses. So just remember that. Ziprasidone starts with the letter Z, and the letters QT are all end of the alphabet letters. So maybe that'll help as well. So prolongation of the QT and ziprasidone. All right, moving on. We have anxiety disorders. So some of the differential diagnoses of the DSM-5 for anxiety disorders would be social anxiety disorders, like social phobia, and that would be an anxiety that's restricted to social and performance situations, or fear of scrutiny and embarrassment. So they'll give you a patient that only has anxiety when they're put in a specific situation. So in that case, that would be social anxiety disorder. Panic disorder would be if they have recurrent unexpected panic attacks, versus a specific phobia, which is an excessive anxiety about one specific object or a situation. So try to differentiate between specific phobia and social anxiety. In a specific phobia, it could be anything, but it's usually an object, versus social anxiety disorder would be anxiety because of a fear of scrutiny or an embarrassment in a specific situation. So I guess social anxiety would be according to the situation, whereas specific phobia would be according to a specific object or a situation. But if in the exam, they'll probably point you in the direction of a specific object. All right, and generalized anxiety disorder would be chronic multiple worrying, anxiety, and tension. I know people that are constantly chronic worriers. They're worried about this, worried about that. Gives them anxiety and tension. And if that's actually impeding on your daily life, that would be given a category of generalized anxiety disorder. So moving on, we're going to delve into this a little bit more in detail. So let's start off with social anxiety disorder, or social phobia, as it's also known as. The diagnosis is marked anxiety about more than one social situation for more than 6 months. There you have your 6-month bracketing that these psychiatric conditions are based off of. More than 6 months at about more than one social situation. Fear of scrutiny by others and humiliation and embarrassment. Social situations are then avoided or endured with very extreme, intense distress, and then marked impairment of social, academic, and occupational situations, because you just don't want to deal with life at that point, whatever it is that you have a phobia to, as well as subtypes specifier, so performance only, such as if you were going to go on stage or give a speech in front of hundreds of people, that's some type of performance anxiety, which is a specific social phobia, or not specific phobia, I'm sorry, it would be a social anxiety disorder or social phobia. Okay, treatment would be in these situations an SSRI or SNRI, as well as cognitive behavioral therapy. Again, if you ever get the option of having both a medical treatment plus cognitive behavioral therapy, always pick both. Beta blockers or benzodiazepines are used for the performance subtype of this disorder. So the beta blockers are preferred. Because benzos can cause sedation or effects in cognition, so you want to kind of avoid that, because you don't want to actually make a fool out of yourself if you're sedated or something on stage. You just want to calm yourself down, and it'll help you perform better on stage. And avoid benzos in substance abuse patients, because benzos again are highly addictive. Cognitive behavioral therapy techniques include social skills training, cognitive reframing of anxious thoughts, and systemic desensitization. All right, moving on. We have panic disorders. Panic disorders are recurrent and unexpected attacks with more than 4 of the following. So they can have chest pains, palpitations, shortness of breath, trembling, sweating, nausea, dizziness, paresthesias, derealization or depersonalization, a fear of losing control or dying, and worry about additional attacks and avoidance of behaviors. So how do you treat panic disorder? Immediately, you want to give benzodiazepine to just calm them down. And then long-term, you calm them down. How do you want to treat them? Long-term is with an SSRI or SNRI, or you can combine that with the cognitive behavioral therapy. All right, panic disorder is recurrent and unexpected panic attacks with more than 4 of the following. So they can get palpitations and sweating, trembling or shaking, shortness of breath, choking sensations, that's a common one, chest pain and discomfort, so it can mimic an MI, right? Nausea or abdominal distress, dizziness and lightheadedness, chills or heat sensations, paresthesias, a derealization or depersonalization disorder, fear of losing control or going crazy, or the fear of dying. These are all symptoms of panic disorders. And this will happen very commonly, at least one attack followed by one or both of the following for more than a month. So they can have worry about additional panic attacks or consequences and changes in behavior related to the attacks, like avoidance. The panic attacks are not attributable to other mental illnesses or substance abuse. So how would you treat panic disorder? You would treat it exactly the same as what we said earlier with benzodiazepine, and long-term with SSRIs and cognitive behavioral therapy. You can also do a benzo like lorazepam. Well, that's not also. Immediately you want to give benzodiazepines. An example would be lorazepam, and once the symptoms are controlled, benzos should then be tapered off due to risk of dependence. And then the diagnosis is mainly clinical, but drug screening, monitoring of vitals, EKGs, cardiac enzymes should all be performed to rule out any type of MI because, again, panic disorder does look like an MI. Comorbidities of panic disorder they could be associated with major depression. Studies have shown that about 60% of patients with panic disorder have at least one lifetime episode of major depression. Bipolar disorder is also associated with panic disorder. Agoraphobia, which is the fear of public places, and approximately 40% of patients meet that criteria of agoraphobia, and substance abuse. And there's also a high risk of suicide attempts and suicidal ideations. Now we can move on to specific phobia, and that would be a marked anxiety about a specific object or a situation. For more than 6 months, again, you have that 6 months time period. Common types of phobias would be phobias of flying, phobias of heights, animals, injections, or seeing blood. Those are all examples. So avoidance behaviors like bridges and elevators, refusing to work, requiring travel like on an airplane or a boat or whatever they're phobic to, the object that they have phobia to. And it's common, around 10% of the population does have some type of specific phobia, and usually it develops in childhood and can develop after a traumatic event. So treatment for a specific phobia, here you want to do behavioral therapy first, such as exposure therapy, like flooding, I believe is the term, right? Flooding. A systemic desensitization as well, and those are the treatment of choices. Short-acting benzos can help acutely, so if a therapist is unavailable or there's just insufficient time, benzodiazepines can be given if there's something going on at this moment. But since this is a specific phobia, they're coming to you because they need help dealing with a phobia. That just means that they need therapy at that time. Okay, not medical therapy. Okay, or pharmacological therapy, I'm sorry. Generalized anxiety disorder is the next one, and this is excessive worrying or anxiety about multiple issues, and that occurs more than 6 months. They're difficult to control. There's more than 3 of the following symptoms. They can have restlessness or feeling on edge. They can have fatigue, difficulty concentrating, irritability, muscle tension, and sleep disturbances, as well as significant distress or impairment. And it's not due to substances or any other type of mental disorder or medical condition. And treatment for generalized anxiety disorder, first line would be cognitive behavioral therapy with an SSRI or an SNRI. And if those don't work, second line would be to give them benzos or buspirone. And buspirone is used in non-depressed patients as well, and in the absence of panic symptoms. So if they have signs of panic symptoms, you don't want to give them buspirone. you actually want to give them a benzo to calm them down first, and then send them home on an SSRI or SNRI with cognitive behavioral therapy. I think you're getting the point. So benzodiazepines should not be used in patients with comorbid depression, substance abuse, because they're what they call downers. They should be used sparingly in elderlies due to slow metabolism and accumulation. So remember that elderly patients have a slower rate of metabolism, so any type of drug that you give them has to be titrated at a perfect amount because they have a very slow metabolism and can linger around their body, causing toxic levels to accumulate. So remember that about elderly patients. And that slow metabolism and accumulation of the drug in elderly patients can cause confusion and an increased risk of falls. Another adverse effect of benzodiazepine is paradoxical agitation. Now, paradoxical agitation is going to be characterized by increased agitation, confusion, and aggression, as well as disinhibition. And it's typically within an hour of administration, although paradoxical reactions of benzodiazepines are relatively uncommon, at less than 1%. They are important to recognize, as increasing the doses of benzodiazepines will only worsen the patient's condition. And discontinuing is going to be the most appropriate next step in the management if a patient starts developing paradoxical agitation.
Okay, the next topic is OCD, or obsessive compulsive disorder, and the diagnostic criteria would be obsessions that are recurrent or intrusive obsessions, anxiety-provoking thoughts, urges, or images, and there's attempts to suppress or neutralize them with other thoughts of actions like compulsions, and it has no relation to other mental or substance use disorders. So these are just straight obsessions. Compulsions are another diagnostic criteria, which are responses to the obsessive thoughts and repeated behaviors or mental acts. They have excessive behaviors that are intended to reduce the anxiety or to avoid any kind of outcome. So their behaviors are not connected realistically with preventing anxiety or the feared event. Obsessions or compulsions, they consume more than an hour's worth of your day, and that causes significant distress, and it interferes with a daily routine or social functioning. Whenever you see that phrase, by the way, as a general rule, that it interferes with daily routine or social functioning, that is a hint for a psychiatric condition. If it doesn't have that, it might just be counseling or whatnot. But if you see that someone's daily routines or social functioning has been compromised, then you're looking more into a psychiatric condition. So be aware of that. Okay, treatment options for OCD would be cognitive behavioral therapy, exposure and response prevention, and or a high-dose selective SSRI. You can also give clomiphene or an antipsychotic for people who do not respond to that treatment, that don't respond to SSRIs. You can give them clomipramine or antipsychotics, and also deep brain stimulation for treatment of severe or refractory cases. So, I mean, if nothing works, the last case scenario would be to stimulate your brain. That would be pretty much anybody's last resort, is to actually get into the brain and do some kind of stimulation there. All right, next topic would be trichotillomania, and that's basically hair pulling. So DSM-5's criteria states that these are recurrent hair pulling, causing hair loss with repeated attempts to decrease or stop the hair pulling. They don't want to be doing this, but they're just doing it. Causes significant distress in their lives. Again, you have that it affects their daily life. That's an issue. It's not due to a medical or dermatological condition such as alopecia. This is just them pulling out their hair, and it's not due to any other mental disorders like body dysmorphic disorders. So it's not a symptom of something else. This is it's a diagnosis in itself. How you treat it is with cognitive behavioral therapy to reverse their habits. So it's like a training form of reversing that habit of hair pulling. The DSM-5 classifies it as an OCD-related disorder to reflect the increasing evidence of shared features that they have with OCD, and because of their higher rates of comorbidity in patients with a personal or family history of OCD. And commonly it affects areas such as the scalp, the eyebrows, and the eyelids. More common in girls and in women, and they have something also called trichophagia, which means when they pull out their hair, they'll eat it. And subsequently, they can actually form a trichobezoar, which remember was like a ball of hair in the intestines or in the stomach. That was from step 1, a bezoar. So that can lead to abdominal pain and even bowel obstruction if it gets too bad. Next one would be hoarding syndrome, and this is a new disorder in the DSM-5. It's distinct from OCD in that it's characterized by the accumulation of large numbers of possessions that may clutter the living spaces to the point that the living spaces are not usable. Patients experience intense distress when they try to attempt to discard any of their possessions regarding their actual value. So it could be somebody collecting newspapers that have no significant value, or newspaper clippings that really have no significant value, and yet it's so many of them that it's impeding their walkway to get into their bedroom. And if you try to remove that, they are extremely held on to this clippings in this example. So they don't want you to get rid of it. So that is a problem. It can also become, if it's extreme, it can cause associations with unsanitary conditions, fire risks, basically because of the blocked exits. And then cognitive behavioral therapy would be the treatment specifically targeted to the hoarding behaviors. That's the most effective treatment, and there's specific techniques to educate the patient, as well as motivational interviewing skills, skill training and organization, and decision-making capacities. Also cognitive reconstruction or restructuring of dysfunctional thoughts, and actual gradual exposure to discarding possessions. So you can say, well, we'll get rid of these little 5 clippings. You don't really need that, and so on and so forth until they're cured, or at least they're stable. Although SSRIs are often tried based on the efficacy in treating the OCD, their efficacy in treating this disorder, the hoarding behavior, without obsessive compulsive disorder is going to be limited. So SSRIs can be considered as an adjunct to cognitive behavioral therapy, and then it can be helpful in treating comorbid depressions and anxiety disorders, but cognitive behavioral therapy in itself is basically first line. Also, I'd like to add a side note that most of these disorders, they require the patient to basically tell you that there's a problem. They have to admit there's a problem. You can't just go out of your way because a family member brought them in and expect the patient to be compliant with any type of treatment that you give them, because they think themselves that this is perfectly fine behavior. Unless they come to you and say, "Doc, this is a problem," then the treatment is always going to be better. Versus if they don't, then no amount of treatment is going to help them, because they're not going to comply with anything you tell them to, because in themselves they really think there's nothing wrong with them. Okay, so just a little adjuvant there. So next disorder would be PTSD, or post-traumatic stress disorder. And the clinical features would be exposures to a life-threatening trauma, as well as nightmares, flashbacks, intrusive memories. There's avoidance of reminders, amnesia of the event. There's emotional detachment and a negative mood towards it, with decreased interest in activities, sleep disturbance, hypervigilance, irritability, and this is going to be lasting more than 1 month. So again, this is that it affects their daily life. Treatment would be a trauma-focused cognitive behavioral therapy, like what
is it that caused you to have the post-traumatic stress disorder? What traumatic experience were you exposed to? And then a cognitive behavioral therapy will be geared towards that. And you can also add an antidepressant to help out with the cognitive behavioral therapy, such as SSRIs or SNRIs. Sexual assault patients and also military veterans are at increased risk of PTSD, along with the risk of developing major depression and a contemplation of suicide attempts. Also, there's an increased risk for medical problems, including sexual transmitted diseases, pelvic pains, fibromyalgia, functional gastrointestinal disorders, and cervical cancer. Those can all be linked to an avoidance of pelvic examinations. Some PTSD symptoms may appear immediately after a trauma. However, sometimes it's often delayed months or even years before you actually start seeing any kind of criteria for the diagnosis. All right, next topic is depression. So we're going to have differential diagnosis of depression, specifically differentials of depressed mood. So you'll have your category of major depression, adjustment disorder with a depressed mood, and normal stress responses. So that's categorism. So in major depressive disorder, you're looking at something that's going to be occurring more than 2 weeks. There's going to have more than 5 of the 9 symptoms of SIGI CAPS. There's going to be a significant functional impairment. There's no lifetime history of mania, and it's not due to drugs or any kind of other medical conditions. So it's just think about a significant functional impairment, again, with their daily lives, with more than 5 of the symptoms of SIGI CAPS. Now, the mnemonic SIGI CAPS, you probably already know this, but the S stands for sleep disturbance, I stands for interest or loss of interest, G is for excessive guilt, E is for energy, so low energy, the C in CAPS is impaired concentration, the A is appetite disturbance, so they won't have an appetite, or they will excessively, or under appetite, or low appetite. The P is for psychomotor agitation or retardation, and the S in SIGI CAPS is suicidal ideation. So if they have 5 of those 9 symptoms, then that is the criteria for major depressive disorder. Now, adjustment disorder with depressed mood would be, you can actually pinpoint the identifiable stressor. The onset is going to be within 3 months of that stressor, so it's more of an acute kind of thing. There's marked distress in the patient. There's significant functional impairment, again, with their daily lives, but it doesn't meet any criteria for other DSM-5 disorders. So here, they have an identifiable stressor that happened within the last 3 months. Specifically, these could be like an automobile accident or witnessing somebody being killed or something very traumatic. And it happened fairly recently, within the last 3 months, and that is significantly causing them distress and impairment. So that is adjustment disorder with a depressed mood. And then you have your normal stress response, and that is not excessive or out of proportion to severity of the stressor. There's no significant functional impairment. These people can actually go about doing their daily lives. They may be thinking about the event or thinking about the stressor, but they're still able to go to work. They're still able to go to school, study, do their normal daily lives. This is just a normal stress response. Okay, so for adjustment disorder, the symptoms rarely last more than 6 months after the stressor ends. And the stressors can be either single or multiple stressors, and it involves emotional or behavioral symptoms such as anxiety, depression, disturbance of conduct, and you want to treat with psychotherapy. That's focused on developing coping mechanisms and improving individuals' responses to and an attitude about stressful situations. So psychotherapy is going to be your treatment in adjustment disorder. For major depression, there's signs and symptoms of major depressions. We already said the SIGI CAPS, sleep, lack of sleep, increased or lack of. There's anhedonia,
decreased interest. Guilt, so they have feelings of worthlessness or hopelessness. They're deficient in energy. They're not energetic. They have a difficulty concentrating. Their appetite can either be increased or decreased. They can have psychomotor retardation or agitation, and actually suicidal ideations. What are the differences between major depression and a grief reaction? So a major depressive episode is basically 5 of the following 9 symptoms. So the 9 Psyche caps, I'm not going to keep going over them, but there's low mood or anhedonia must be present. It can occur in response to a variety of stressors, including a loss of a loved one. The duration here has to be at least more than 2 weeks. And there can be social or occupational dysfunction, and suicidality is going to be related to hopelessness. They feel hopeless and worthless. Maybe the stock market crashed and they lost all their money, and now they feel suicidal and they can't even function in life. And right there and then, that's the diagnosis for major depression. A grief reaction or bereavement is going to be a normal reaction to the loss. Feelings of loss or emptiness. The symptoms are going to revolve around the deceased person. Functional decline is going to be less severe. The grief is going to occur in waves. There's also going to be feelings of worthlessness, self-loathing, guilt, but there's not really a feeling of suicidal tendency there. That's not as common, but they do feel extremely sad. It's more specific towards the deceased person. That's why they're grieving. Thoughts of dying involve joining the deceased person. They had a strong connection to their loved one and they just want to join the deceased. There's also the intensity is going to decrease over time, so the time frame there would be weeks to months. Now there's also subclassifications of depression. You have melancholic depression, atypical depression, and depression with psychotic features. So a melancholic depression would be a subtype of major depression that's characterized by anhedonia, absent mood reactivity, a depressed mood, and that's typically worse in the morning. You have insomnia or early morning awakenings. They get up early in the morning with loss of appetite, so they have weight loss. They are they feel guilty excessively with psychomotor agitation or retardation. And that subtype its psychomotor changes are more common in older adults. So that would be a melancholic depression, older adults. But if you see something that involves hypersomnia, they're constantly sleeping with an increase in appetite, and they basically are not very sensitive to anything anymore, and now they have physiological feelings of heaviness in their limbs. That's an atypical depression. And then versus major depression with psychotic features, that is going to be basically an elderly patient who has depression to the point of suicidal ideations. So in those cases, you want to treat with electroconvulsive therapy. The reason, again, is because remember we said earlier that in the elderly population, their metabolic, their metabolism is slowly reduced, so they're going to have an increased of the concentration of whatever drug you give them in their system. So it's going to take them longer to eliminate antipsychotic drugs, antidepressants, any type of medication. They're slower renal function. They have a decline in renal function normally. So you want to avoid any of these heavy medications. So just go straight into electroconvulsive therapy because it is a rapid response. It's a very quick procedure, has very low side effects, if not any, and it's just preferred over the medical pharmacological therapy. All right, next topic would be dysthymia, which is a persistent depressive disorder. The DSM-5 categorizes it as a chronic depressed mood that lasts more than 2 years, 1 year in children or adolescents. There is no symptom-free period for at least 2 months, so this is happening more than 2 months. The presence of at least two of the following, so they'll have poor appetite or overeating, insomnia or hypersomnia, low energy or fatigue, low self-esteem, poor concentration or difficulty making decisions. There could be feeling of hopelessness, and with a pure dysthymic syndrome, it's a criteria for major depressive episodes that's never been met, with intermittent major depressive episodes, and they can also be with persistent major depressive episodes, and that criteria is for major depressive episodes that's met previously for the previous 2 years. Okay, so moving along, we have antidepressants, and there's several classifications of antidepressants. First, you have your SSRIs, your SNRIs, your NDRIs, TCAs, MAOIs, and other medications. So let's start off with SSRIs. These are selective serotonin reuptake inhibitor. That's what it stands for. You have your fluoxetine, paroxetine, sertraline, citalopram, escitalopram, and fluvoxamine. Be careful with citalopram and escitalopram, because that sounds like a benzo, but it's actually an SSRI. Citalopram, escitalopram. SNRIs would be your serotonin and norepinephrine reuptake inhibitors. Those are your venlafaxine, desvenlafaxine, and duloxetine. You have your NDRI, which is norepinephrine and dopamine reuptake inhibitors. The NDRI, the one that we should know, is bupropion, and though that bupropion, it helps with smoking cessation, so that's a big one. No weight gain, so there's no weight gain involved. No hypersomnia, so that's good, and no sexual dysfunction as well. So those are really good benefits for bupropion, and they will be tested on. They'll have which of the following will help with this patient, and they'll give you a patient who wants to stop smoking, bupropion. They'll give you a patient who says that he really doesn't want to gain weight anymore. Switch him to bupropion. Contraindications, however, would be seizure disorders, because they do cause seizures. It's known to cause seizures. So if they are suffering from a seizure disorder, that's contraindicated. Also, patients who are bulimic, because this medication does not cause weight gain, and we want patients with bulimia, nervosa, and anorexia nervosa to actually gain weight. So that would be a contraindication. And if they've had any type of MAOI use within the past 2 weeks, if they've been on like phenelzine or tranylcypromine within the past 2 weeks and you want to change them, this would be a contraindication. So you would not want to give bupropion in those cases. So caution needed when there is an abrupt withdrawal of sedative hypnotics and co-administration with other drugs that lower the seizure threshold, because again, this medication is known to cause seizures. TCAs are your tricyclic antidepressants, your amitriptyline, nortriptyline. You'll see later on that these tricyclic antidepressants, although they are classified as antidepressants, are usually used as pain management. So go figure, but that's what it is. And you have your MAOIs, which are your monoamine oxidase inhibitors. Again, your phenelzine, tranylcypromine. And both TCAs and MAOIs are never first line because they have the greatest side effect profile. You want to give them 5 weeks after a washout period when you've taken fluoxetine and before starting an MAOI, basically to avoid serotonin syndrome. Other antidepressants would be mirtazapine, trazodone, and vortioxetine. All right, so parents of adolescents patients should always be notified when the patient is at risk to themselves or to others, or when starting a psychotropic medication. If the patients are not suicidal and they simply just want to discuss his or her depression or obtain psychotherapy referrals, and his request for confidentiality should be respected. Patients with a single episode of major depressive disorder who do respond to actual treatment should continue the antidepressive medication for an additional 4 to 9 months, and that would be a continuation phase treatment. There is a significantly increased risk of a depressive relapse in patients who suddenly discontinue their antidepressants earlier than 4 to 9 months. So if you have a patient who says, "Thanks, doc, this has been working great, and it's only been 2 months of treatment or 3 months," what would be the next thing? Do you want to wean them off or what? No, you actually want to continue them on for at least 9 months, 4 to 9 months. The dose should be maintained at the level that achieved remission, and it shouldn't be reduced. The dose that gets the patient well keeps the patient well, is what you should know. So the maintenance phase treatment is going to be defined as continuing the antidepressive medication past the initial continuation phase treatment. Maintenance therapy is about 1 to 3 years. That would be appropriate for patients with a history of multiple episodes, like recurrent major depressive disorder, and for chronic episodes that last more than 2 years with a strong family history, or if they've had severe episodes like that suicide is attempted, that would be an indication. Patients with a history of highly recurrent lifetime episodes, more than 3 lifetime episodes, and very severe episodes, chronic major depressive episodes, those all should be continuing on with maintenance treatment indefinitely. So in those patients, no matter how much they want to ask you, can we be weaned off, because of their past history and risks, you just want to continue them. You want to continue them on indefinitely. When should you taper or discontinue? When there's failure of initial SSRI treatment, so you'd want to increase the dose to its maximum therapeutic dose. Then you'd want to do adequate duration of more than 6 weeks, where you'll see minimal or no improvement. Then you want to switch to another first-line antidepressant with a different, let's say an MAOI or an SNRI. And other options would include adding a second agent, especially in those with that have some benefit but not complete improvement, with either adding or switching that pharmacotherapy. So it's all this is all tailored therapy, in other words. So you kind of want to see where the patient's at. Have they been doing better with it or minimally better? If not, do you want to switch them to the same class, maybe a different class? Do you want to add a different class and maintain them on a current one because it's having a little bit of benefit here but not enough there, so you want to add another medication? Everything's tailored in this case. So patients undergoing chemotherapy also that have a low threshold of depression and starting SSRIs, the first step in management would be pain control, obviously, because chronic pain can lead to depression. Mirtazapine's side effect, that's weight gain and sedation. And trazodone is very sedating, and it's used in insomnia related to depression. So if there's depression with insomnia, trazodone would be a good treatment. Now, coming back to the topic of electroconvulsive therapy, or ACT, when would these be a good condition? Like we said, first of all, in elderly patients with major depression, or with unipolar and bipolar depression, catatonic patients, and patients that have bipolar mania. So what are some of the specific indications? If there's treatment resistance to other medications, if it just didn't work, or if they have psychotic features present, or in any type of emergency condition, such as in pregnancy, that's a good one, refusal to eat or drink, or imminent risk of suicide, you want to treat them ASAP with a very quick treatment, minimal side effect profile, electroconvulsive therapy.
And then pharmacotherapy is contraindicated due to the comorbid medical illnesses and poor tolerability. And also, if they've had a history of response to electroconvulsive therapy, that would be also a good indication to continue on doing that treatment. Because again, that would be last resort anyway. The safety is that there's no absolute contraindications to electroconvulsive therapy. There is an increased risk of severe cardiovascular disease, or if patients have had recent MI, or if they have a space-occupying brain lesion or a recent stroke, or if they have some type of unstable aneurysm, then that would be a contraindication. So you want to perform. It's performed under general anesthesia, and it's one of the most common side effects of ECT would be amnesia. It can be a retrograde amnesia, so like forgetting recent memories. That tends to last longer, especially of events occurring during the ECT, or it could be anterograde amnesia, such as retaining new memories, but that resolves rapidly. There's an increased risk of fractures, especially in osteoporotic patients, but not as common as amnesia. You want to do close monitoring of muscle relaxation with succinylcholine, and that has decreased the incidence of bone fractures if they do have an increased risk of osteoporosis. All right, next topic would be postpartum blues, depression, and psychosis. So postpartum blues, the prevalence of that is 40 to 80%. So this is fairly common. The onset occurs within 2 to 3 days, and it resolves within 10 days. Symptoms would be mild depression, tearfulness, irritability. And basically you just want to reassure these patients and monitor them because it does go away in 10 days, and it's fairly common. Versus postpartum depression, that is actually least common or less common. Only 8 to 15% of the population has this. Usually happens within 4 weeks. Their symptoms are moderate to severe depression. They'll have sleep or appetite disturbance, low energy. They can have psychomotor changes. They can feel guilty, lack of concentration, or they can even go as far as to having suicidal ideation. And treatment for postpartum depression would be antidepressants and psychotherapy. And then finally, you have your postpartum psychosis, which thankfully it's the least prevalent at only 0.1 to 0.2% of the population. This occurs. Its onset is variable. It can happen within days to weeks. Symptoms would be delusions or hallucinations, thought disorganizations, and bizarre behavior. So all the symptoms of standard psychosis is just happening postpartum. And their treatment would be antipsychotics and antidepressants. And you don't want to leave the mother alone with the infant because there's a risk that the mother can kill the infant. So if you see a vignette that says that she's doing something for she's seeing things, or voices are telling her to kill herself and the baby or something like that, those are obviously red flags, and that is not normal by any means. So you want to admit the patient and don't leave the mother alone with the patient. You don't want to discharge these patients, and you want to treat them with antipsychotics and antidepressants immediately. Okay, next would be bipolar disorder, and that is bipolar disorder and its related disorders. So we can classify these, first of all, as either manic episodes or hypomanic episodes, and then we'll go into bipolar 1, bipolar 2, and cyclothymic disorder. So bipolar disorder, its manic episodes are symptoms that are more severe. It's usually 1 week long unless hospitalized. They'll have marked impairment in social or occupational functioning or hospitalization necessary. It may lead to psychotic features, and that makes the episodes manic by definition. So those psychotic features are basically a manic episode. Then you have your hypomanic episode, which are less severe symptoms that occur more than 4 consecutive days long. So a little bit less than a week. It'll be unequivocal with observable changes in functioning from the patient's baseline. So symptoms are not going to be severe enough to cause marked impairment or necessitate hospitalization with these patients. And the key here is that there are no psychotic features. So it'll be very less severe symptoms of mania, but with no psychotic features. So then you have your bipolar 1, and bipolar 1 is basically defined as manic episodes. They have depressive episodes. That's common, but it's not required for the diagnosis. The diagnosis of bipolar 1 are basically manic episodes, versus bipolar 2 are hypomanic episodes. There's episodes of mania, but there's more than one major depressive episode required. So they'll have mania and a depression at some point in time. That would be bipolar 2. Just think of it as 2 episodes, manic and depressive. Bipolar 2, bipolar 1, only manic. They could have depressive episodes, but that's not common and it isn't required. So bipolar 1, only manic. Bipolar 2, hypomanic episodes with at least one or more major depressive episodes. And then finally, you have your cyclothymic disorders, which is at least 2 years of fluctuating in and out of mild hypomania and depressive symptoms that do not really meet criteria for hypomanic episodes or major depressive episodes. It's just a waxing and waning kind of deal, but it's lasting for more than 2 years, and that would be cyclothymic disorder. So let's break these down a little bit more in detail. So acute mania, its clinical features would be elevated, irritable, and labile mood. They'll have increased energy, increased activity. They'll have a decreased need for sleep. They have pressured speech and racing thoughts and distractibility. Almost like ADHD, but less severe. Or more severe, sorry. Grandiosity, risky behavior. They'll have pressured speech, marked impairment, and they could have psychotic symptoms as well. And how would you manage acute mania? First line would be your antipsychotics. It could be either first or second generation. Second generation, again, risperidone because of its more rapid onset of action. And you always kind of want to give second generation antipsychotics before you give first generations. Kind of counterintuitive there, but second generations have less side effects profile, like we already mentioned, and out of all of them, risperidone is the treatment of choice, although it does have the highest side effect profile of all the second generation ones. It is more rapid onset of action, so you want to kind of give that first for acute mania. You can also give lithium, but you want to avoid in patients that do have renal disease, because lithium does cause a renal failure. Valproate can also be used, but you want to avoid valproate in patients with liver diseases. Carbamazepine, lithium, valproate, they all require gradual titration over several days. So you don't want to give them for patients with liver disease, because these are metabolized in the liver and not in the kidney. Also, combinations in severe mania, you can give antipsychotics with lithium or valproate, and you can also give as an adjuvant benzodiazepines for patients that have insomnia, or if they are agitated, you can give the benzos. So some of these manic episodes are classified as more than 1 week unless they're hospitalized. So more than 1 week of persistently elevated or irritable moods and increased energy or activity, and as well as more than 3 of the following symptoms. So 4 of these if there's mood or they're just irritable. So more than 3 of the following. So a decreased need for sleep, symptoms of grandiosity, pressured speech, racing thoughts like flight of ideas, distractibility, hyperactive or psychomotor agitation, and risky behaviors like spending a lot of money, having lots of investments, and sexual indiscretions. These are all symptoms of manic episodes, and you only need more than 3 or more to make the diagnosis. There's also marked impairment of typically necessitates hospitalization, and psychotic features can also be present. So there's a mnemonic called DIGFAST, and that stands for distractibility, impulsivity, or indiscretion. The G is for grandiosity, or the F is flight of ideas. A is for increase in activity. S is for sleep. So there's a decrease in sleep. And also talkativeness, or T. Okay, so moving on, we have guidelines for lithium therapy. So what are some of these indications for giving them lithium? So mania due to a bipolar disorder, that's an indication. But contraindications, remember, chronic kidney disease, you shouldn't give lithium. Also in patients with heart disease, or if they have hyponatremia or diuretic use, you should avoid lithium. Baseline studies before giving lithium would be to check their BUN, their creatinine, calcium levels, and your urinalysis, because again, these can cause renal failure. Lithium can cause renal failure. And thyroid function tests as well. And you want to do an EKG in patients with coronary risk factors because heart disease is a contraindication. Adverse effects, acutely, they'll have tremors, ataxia, and weakness, polyuria, polydipsia, vomiting, diarrhea. They'll have weight gain and cognitive impairment. And then chronic adverse effects would be nephrogenic diabetes insipidus. That can also cause chronic tubulointerstitial nephropathy that rarely progresses to end-stage renal disease, but that's what it can cause, nephrotic diabetes insipidus. Also thyroid dysfunction. That's why you also want to check their thyroid function tests, and hyperparathyroidism, because it does cause an accumulation of calcium. All right, and pregnant women should either avoid lithium or adjust the dose during pregnancy, because that can cause complications within the first trimester, as most complications occur within the first trimester, like Epstein's anomaly. And in the later stages, they can get polyhydramnios, diabetes insipidus, floppy infant syndrome, which is a transient neonatal neuromuscular dysfunction, as well as a goiter. And lithium has a narrow therapeutic index and can easily cause toxicity. So those drug levels should be monitored every 6 to 12 months and 5 to 7 days after any dose changes or after starting other medications that can interact with lithium. So what are some of the common what are the common drugs affecting lithium levels? Diuretics can do it, can affect lithium levels. NSAIDs, except for aspirin. SSRIs can affect lithium levels. Angiotensin converting enzyme inhibitors, ACE inhibitors, and ARBs, or angiotensin receptor blockers. And anti-epileptics like carbamazepine and phenytoin, because they can rev up the P450 system. So that's a lithium can affect the lithium can be affected by anti-epileptics. So if a patient has an increase in creatinine level, then you'd want to give them valproate. Remember, you don't want to give them lithium, so you do valproate with periodic liver function tests, because again, valproate does cause changes within your liver enzymes. And you want to monitor the liver function tests and platelet count needed due to a rare side effect profile of hepatotoxicity and thrombocytopenia, because again, your platelet and your coagulation factors are made in the liver. Management of acute bipolar depression, commonly used medications would be your second generation antipsychotics. Those would be quetiapine or lorazepam, and anticonvulsants like lamotrigine. Lithium, valproate, and the combination of olanzapine and fluoxetine also have been shown to have some efficacy. And then antidepressive monotherapy, you want to avoid that because there is a risk of precipitating mania. So you don't want to, in a patient with bipolar, you don't want to give them just an antidepressant because you're making the mania worse. If necessary, you can use in a combination with mood stabilizers like lithium or valproate, second generation antipsychotics. Those decrease the risks and decrease the risk to switch to mania. So lamotrigine has the greatest efficacy for bipolar depressive episodes and can cause Sjogren's syndrome but in very low prevalence in only 0.1% of patients. So that's a good medication, lamotrigine, but it can cause Stevens-Johnson syndrome. Not Sjogren's syndrome, I'm sorry, Stevens-Johnson syndrome. Maintenance therapy. So for lifelong illnesses, this is going to require maintenance to decrease the risk of recurrence. Most require maintenance for many years, but lifetime maintenance is indicated for those with severe courses, like highly recurrent episodes, suicide attempts, severe symptoms and impairments requiring hospitalizations. And that can lead to, let's say, if the patient wants to stop the medication because of a strong therapeutic alliance, there's a psychoeducation involved, and adjunctive psychotherapy can also help the patients accept the chronic nature of that illness and enhance their adherence. So if the patient still insists on stopping the medication, you want to slowly taper over weeks to months and frequently monitor them to identify any type of early signs and symptoms of recurrence. So basically, you just want to maintain them lifelong with these medications unless they really truly want to stop doing it. Slowly taper them off and then just observe them, monitor them for any type of signs of recurrence. Maintenance treatment typically is going to involve continuation of the mood stabilizer, and that's used to treat any kind of acute mood episodes. And evidence-based options are going to include lithium, valproate, quetiapine, and lamotrigine. Patients with inadequate responses to these monotherapies or severe episodes like psychotic features, or they get aggression, or if they have a high risk of suicide, or frequent episodes with marked impairment of requiring hospitalization, that will often then require a combination therapy of lithium or valproate combined with any type of second generation antipsychotics like quetiapine, preferably over risperidone because of its higher side effect profile. And that's recommended as first line to do a combination. If the antidepressant is used in acute depression, it should be tapered slowly and it should be discontinued in maintenance treatment. Now, disruptive mood dysregulation disorder, this is an individual with disruptive mood dysregulation, and that can display with severity, by severity, so severe pervasive irritability and poor frustration tolerance. So they're very frustrated, very irritable individuals, and that results in frequent temper tantrums or temper outbursts. That's called disruptive mood dysregulation disorder. So somebody who's see is in a vignette somebody who has just always irritable, always frustrated, has temper tantrums. Disruptive dysregulation mood disorder. That's what that is. Okay, now for sleep disorders, you have poor sleep hygiene, and that would be inadequate sleep hygiene. That is the next topic. So inadequate sleep hygiene is a sleep disorder due to performance of daily living activities that are inconsistent with the maintenance of a good quality sleep and full daytime alertness. Examples of poor sleep hygiene practices include poor sleep scheduling with variable wake and sleep times and frequent daytime napping. There's a routine use of caffeine, alcohol or nicotine, especially in the periods that precede the sleep. So engaging in mentally or physical stimulating activities that are too close to bedtime all can give you poor sleep hygiene, as well as frequent use of the bed for activities other than sleep. Hint, hint. So all these are types of poor sleep hygienes. Okay, so insomnia disorder would be insomnia for more than 3 nights a week or for more than 3 months. That would give you insomnia disorder. Narcolepsy is that patients are advised to maintain poor sleep habits, minimize alcohol, and avoid medications that can cause drowsiness and worsen the symptoms. In addition, a number of medications can be used to treat the symptoms of narcolepsy. So some of these symptoms, the ones used on UWorld would be modafinil and armodafinil. Those are the dafinils. Those are for narcolepsy. These address excessive, uncontrollable daytime sleepiness that's considered chemically to be a novel stimulant, and it's the preferred treatment for narcolepsy because it's a very mild stimulant. Amphetamine stimulants would be like your methylphenidate, your dextromethorphans, dextromethamphetamine, methamphetamines. These have been traditionally used but aren't currently considered first-line treatment anymore because of their high risk of abuse. There's a potential tolerance with these medications, and there's significant side effects with them. So for instance, if a patient can become tolerant to their dosages in time, and by the time they reach maximum dosaging, then it could potentially not even be beneficial to them anymore, but they're still hooked on it. So that's why it's not first line anymore. So then you have sodium oxybate, and this reduces cataplexy due to the potential for abuse and illicit use. Both sodium oxybate and amphetamines are regulated as controlled substances in the United States. So for narcolepsy, just remember modafinils or armodafinil. All the ones that say dafinil for narcolepsy. Then you have something called advanced sleep phase syndrome. And what this is that it's a circadian rhythm disorder characterized by the inability to stay awake in the evening. And that's usually after 7 p.m. You can't stay awake. It makes social functioning very difficult. These patients frequently complain of early morning insomnia due to their early bedtime. The next one would be delayed sleep phase syndrome. And this is another circadian rhythm disorder that's characterized by the inability to fall asleep at normal bedtimes. Normal bedtimes being 10 p.m. to midnight. So remember, in this exam, everything's very generalized, so this may not be a normal time for you, but for the majority of the population, normal bedtimes are 10 p.m. to midnight. So this is a sleep onset insomnia and excessive morning sleepiness. So these patients often cannot fall asleep until almost about 4 to 5 a.m. But their sleep is normal if they're allowed to sleep until late morning. Unfortunately, society and the pressures in society make this kind of treatment impossible. Who's going to explain to their boss, hey, I can't come into work at 8 a.m. because I have delayed sleep phase syndrome, so I'm just going to have to come in around noon. Yeah, that's not going to fly. So sleep is normal when they are allowed to set their own schedules. They describe themselves as night owls, and the onset is usually in adolescence, and they may respond to treatments such as light or behavioral therapy, and an accurate history and sleep diary are essential for making the diagnosis. So that's called delayed sleep phase syndrome. Easy enough because it's delayed. Now the other one's called shift work sleep disorder. Shift work sleep disorder involves a recurrent pattern of sleep interruptions due to a shift work, causing difficulty in initiating and maintaining sleep at daytime sleepiness. This disorder is usually due to a work schedule that is incongruent with normal circadian clocks. So this could be a patient who has been working a normal shift from 9 to 5, and suddenly they've been asked to take the overnight shift. So now they're working from 5 p.m. to 8 a.m. or something like that. Or that's actually kind of crazy. Maybe 8 p.m. to 8 a.m. or something like that, where they're sleeping now during the day and having to work at night. This can cause a transient inability to fall asleep at their new normal times. So this is called, but it's due to their work situation. So it's their shift work sleep disorder. Most of these are pretty easy to remember because of the way they're described. You have shift work sleep disorder, delayed sleep phase syndrome disorder, advanced sleep phase syndrome disorder. So delayed, advanced, shift work, that's pretty easy to remember. Example would be like the next one, age-related sleep changes. These are sleep patterns that tend to change in older individuals. Whereas the people age, they typically sleep less at night and they nap during the day. The periods of deep sleep, which is stage 4 sleep, becomes very short and eventually it disappears. So older people often awaken more during all stages of sleep. These changes are normal and are usually not an indication of a sleep disorder. This is just very normal behavior. The next one would be night terrors. These occur specifically in non-REM sleep. The child, it's usually fine in children. You get a child that cannot be fully awakened, the child cannot be fully awakened during the episode, and it lasts for a few minutes. But here's the clue here, is when they wake up, they have no memory of the event. That's a night terror, means a child that's having, it looks like he's having a nightmare, but it's not a nightmare, it's a night terror, because when you ask him, so what happened, and they have no idea. Most common in children's 2 to 12, and it peaks at 5 to 7 years of age, and it's usually resolved spontaneously as the child ages, and this can be triggered by acute stress or sleep deprivation or illnesses or meds that affect the CNS. Then versus nightmare disorder, which this occurs during REM sleep. So what we said earlier, night terrors are non-REM, nightmare is during REM, and it's usually in the middle of the night and early morning. The child is fully asleep during a nightmare and doesn't scream or cry or become tachycardic, such as in night terrors they do. And they're fully alert when they wake up. And when you ask them, so what happened? I just had a nightmare, is what they will tell you, because they can recall the nightmare. So in a nightmare, the child can tell you what happened. They can recall the nightmare. In a night terror, they cannot. In a nightmare, the child is fully asleep, wakes up. When you shake them up to wake up, they can wake up. In a night terror, a child cannot be fully awakened during an episode, and in a night terror, they do scream and cry and all that. Okay, so next topics would be eating disorders. So eating disorders can be classified as either anorexia nervosa, bulimia nervosa, or a binge eating disorder. So in anorexia nervosa, the BMI is going to be less than 18.5. They're going to have intense fear of gaining weight, and they have distorted views of their own body, of their weight and shape. And how do you treat anorexia? With cognitive behavioral therapy. You treat them with nutritional rehabilitation, and often if they do not respond to cognitive behavioral therapy or nutritional rehabilitation, then you start them on medications such as olanzapine. Remember, olanzapine was the antipsychotic that causes weight gain, because it's the first letter is an O, so it causes weight gain. There you go. It's given to anorexia nervosa. Now for bulimia nervosa, These are recurrent episodes of binge eating, but binge eating can be seen in all the eating disorders, but they do have recurrent episodes of binge eating. Binge eating is then followed by a compensatory behavior to prevent weight gain, so they'll try to vomit, for instance. But then again, anorexia nervosa also vomits, so that doesn't tell you much either. In bulimia nervosa, they have excessive worrying about their own body weight and shape. That doesn't tell me much either. But here is the difference between bulimia and anorexia. In bulimia, their body weight is normal, so their BMI is between 18.5 to 30, versus anorexia nervosa, their BMI is less than 18.5. Now, the treatment for bulimia nervosa, again, is the same. It's cognitive behavioral therapy and nutritional rehabilitation. But since they do not need to gain weight, since their body weight is normal, you can give them an SSRI, like fluoxetine, and that often is given in combination with the cognitive behavioral therapy and the nutritional rehabilitation. So in bulimia nervosa, remember that their treatment is going to be an SSRI, not an antipsychotic, and that their body weight is going to be normal, versus in anorexia, their body weight is going to be less than 18.5 for BMI. Okay, and then you have binge eating disorder, and these would be recurrent episodes of binge eating with no compensatory behaviors, and they have a lack of control during eating. So in this case, binge eating disorders, they don't have a problem with their image per se. They just have a lack of control of their meals. They have to be eating constantly. So again, you want to start them off with cognitive behavioral therapy, behavioral weight loss therapy if they're probably going to be gaining weight, and pharmacological treatments would be like topiramate and something called, I'm going to try to pronounce this, lisdexamfetamine. So lisdexamfetamine is, I'm assuming, I've never seen this one before, I'm guessing it's an amphetamine, and amphetamines are a stimulant that cause weight loss. So that would be a pretty good treatment for binge eating disorder in these patients who, it doesn't say here, but it's pretty obvious that they're going to be having weight gain. So to go into detail with these eating disorders, in anorexia nervosa, they could have binge eating or purging subtypes, like we said earlier, but the main difference here is in the weight. They have a restrictive there could be a restrictive subtype, meaning that they have fasting or hyper exercising. They could be exercising a lot of times a day, taking a lot of classes at the gym or something like that. And then hospitalization and acute stabilization, it's highly recommended due to dehydration and electrolyte disturbances such as hypokalemia or hypophosphatemia. They can have bradycardia or severe weight loss. Remember that anybody that has a very, very low BMI may require hospitalization. And by a low BMI, we're talking less than 18, less than 18. There's a new question somewhere in UWorld that I forgot. I have to look it up, but it tells you this patient has basically anorexia nervosa, and they're telling you that their BMI is 18.5. What would you do next? But since they were normal, they didn't have any symptoms of dehydration. In this case, what you do is you just send them home. It's not to hospitalize them. So also look for blood pressure readings. If their blood pressure is less than 80/60, you'd want to hospitalize. But if it's 90/70, you don't hospitalize. So that could be tricky. You want to also supervise their meals, and some patients will require nasogastric tube feedings during the onset of anabolism, which is it's the opposite of catabolism, which is the breakdown. This is basically the gaining of weight. Patients will require close monitoring and refeeding syndrome. Now, refeeding syndrome is when you have electrolyte depletions and arrhythmias and heart failure, and that's due to fluid and electrolyte shift imbalances. So, I mean, think about it. This patient hasn't been eating normally, and suddenly you're introducing to them all these nutrients and electrolytes, and those electrolytes, that rush of potassium and calcium and sodium, can cause arrhythmias, and it can lead to heart failure very quickly. So that can result from those electrolyte imbalances. There could be also vitamin deficiencies, and that should be assessed and supplemented if there is any type of deficiency that you identified. You'd want to correct that. All right, next topic is bulimia nervosa. This is another binge eating and inappropriate compensatory behaviors that occur once a week or 3 times a month, or for 3 months in order for the diagnosis to be made. So you have signs of bulimia, which would be hypotension, tachycardia, dry skin, menstrual abnormalities, and electrolyte abnormalities as well, like hypokalemia, hypochloremia, metabolic alkalosis. There could be erosions of dental enamel and parotid hypertrophy in patients who vomit frequently. All right, so the next topic is body dysmorphic disorder. Okay, so in body dysmorphic disorder, the clinical features are they have a preoccupation with more than one perceived physical defect. The defects are not observable or appear slight to others. They appear slightly different to other people. There's a repetitive behavior or mental acts that are performed in response to the preoccupation, and there could be significant distress or impairment. There's a significant or a specific insight of either good, poor, or absent delusional beliefs. And again, body dysmorphic disorder can be found in both anorexia and bulimia. And their management is with antidepressants. So you give them SSRIs. Cognitive behavioral therapy also, you always want to do CBT, or cognitive behavioral therapy, in conjunction with pharmacological treatment such as antidepressants. All right. So the next group of disorders that we're going to speak about is dissociative disorders. So in dissociative disorders, you have 3 types. You have depersonalization or derealization disorder, you have dissociative amnesia, and you have a dissociative identity disorder. So for depersonalization, derealization disorder, this means that the patient has persistent or recurrent episodes of either one or both of the following. So they can have persistent or recurrent experiences of either depersonalization, which is feelings of detachment from or being outside an observer of oneself. So you're like detached from your own body kind of view. And then there's or they can have derealization, which is experiencing surroundings as being unreal. So they'll be in a room, but they don't think that room is real. Or they can have both, being a sense of detachment with experiencing as their surroundings being unreal. So that's depersonalization, derealization disorder. But they have intact reality testing. Okay. Then you have something called dissociative amnesia. This is the inability to recall important personal information, usually of a traumatic or stressful nature. It's not explained by any other disorder, like substance use or post-traumatic stress disorder. This is somebody who just forgot personal information that you should always remember, like your address, your telephone number. Versus dissociative identity disorder means that this is marked discontinuity in identity or the loss of personal agency with fragmentation into more than two distinct personality states. It's associated with severe trauma or abuse. This can be like your multiple personality disorder. It's now called dissociative identity disorder. All right. Then you have, so for dissociative amnesia, the specifier with with dissociative fugue is used when amnesia is associated with seemingly purposeful travel or bewildered wandering. Okay, so like they are in an airport and they don't know how they got there. Next one would be somatic symptom and related disorders. So here you have somatic symptom disorders, you have illness anxiety disorders, conversion disorder, which is also known as functional neurological symptom disorder. There's also factitious disorder and malingering. So for somatic symptom disorder, this is basically excessive anxiety or a preoccupation with more than one unexplained symptom. In illness anxiety disorder, however, you have fear of having a serious illness despite few or no symptoms of consistently negative evaluations. Okay, so what's the difference with these two? In the somatic symptoms, you have excessive anxiety with more than one unexplained symptom. I'll have GI pains, but you do all testings for GI and there's nothing that'll explain your stomach pains. Versus illness anxiety disorder is a fear of having serious illnesses despite having either few or no symptoms at all, and they're consistently negative evaluations. So fearing of having the consequence of an illness is called illness anxiety disorder, versus the preoccupation of excessive anxiety due to a symptom is a specific thing. That's a specific somatic symptom disorder. It's a little confusing, but I think we broke it down fairly easy. Then you have conversion disorder, which is also known as functional neurological symptom disorder. And that is basically neurological symptoms that are incompatible with any known neurological disease. And it's often acute onset associated with stress. Okay, and then you have factitious disorder. And in factitious disorder, there's an intentional falsification or inducement of symptoms with a goal to assume the sick role. So these patients, they are going to make believe that they're sick just because they want to feel sick. Kind of like if you like it when they bring you ice cream in bed because you got sick. So you'll play the sick role so that you keep getting ice cream in bed. Kind of, that's a simple way of seeing it, but that's what it is. You're falsifying your disorder in order to get something out of it, a reward. All right, so malingering is your next topic. That is falsification or exaggeration of symptoms to obtain external incentives or a secondary gain. So be careful here with factitious disorder versus malingering. So in factitious disorder, you're actually not doing it for the ice cream. You're just doing it because you want to be sick. You want to look like you're sick. But for malingering, you're doing it for the ice cream. You're doing it because you want to not go into work that day and you call in sick. So that's malingering. All right, next topic in more detail would be somatic symptom disorder. We said that somatic symptom, its clinical features was more than one somatic symptom causing distress and functional impairment. The thoughts are going to be excessive, or behaviors are going to be related to the somatic symptoms. Symptoms are going to be unwarranted, persistent thoughts about seriousness of symptoms that don't really exist. And they can have persistent anxiety about it, about their health or other symptoms. and they can have excessive times and energy devoted to those symptoms, and that can last more than 6 months. Back again to our rule of 6 months with psychiatry disorders. So again, these patients are worried about specific symptoms, and how do you manage them is with regularly scheduled visits with the same provider. So usually on the test question, they'll ask you, what would you do next? And it would be to reschedule and reevaluate them in like a month or a week or 2 weeks. You want to limit unnecessary types of workups and specialist referrals. You never want to refer anyone on the boards anyway. And you don't want to do a lot of working up on these people, even though they may ask you to. Your response would be, let's see what happens in 2 weeks. You want to legitimize symptoms but make functional improvements to the goal. And you want to focus on stress reducing and improving on their coping strategies. Mental health referral is if the patient will accept it. All right, next topic is going to be conversion disorder, and this is a functional neurological symptom disorder. Common presenting symptoms would be weakness or paralysis, non-epileptic seizures, and movement disorders. They also present with speech or visual impairment, as well as swallowing difficulties and sensory disturbances, as well as cognitive symptoms. So what are some of the diagnostic criteria for conversion disorder? You have symptoms of altered neurological function, as well as voluntary motor or sensory function. It's going to be altered. It's often precipitated by psychological stressors. It's not feigned or intentionally produced as infectious disorder and malingering, but findings are incompatible with a recognized neurological condition. Symptoms can cause significant social or occupational impairment, and there's treatment options which are usually stepwise. So first you want to educate the patient with self-help techniques. Then second line would be cognitive behavioral therapy if education and self-help techniques don't work. And finally, physical therapy for motor symptoms. And then patients can be hysterical or strangely indifferent to their symptoms. Differential diagnoses require extensive workup to rule out other possible underlying medical causes. There's also another condition called pseudocc's, and this is a fairly an uncommon condition, and it's basically when a woman presents with many signs and symptoms of pregnancy. She'll present with amenorrhea, she'll have enlargements of her breast and the abdomen, she'll even present with morning sickness, weight gain, sensations of fetal movement, and they've even reported positive urine pregnancy tests per the patient. How strange is this? And then ultrasound, however, is going to reveal that there is a normal endometrial stripe and that the pregnancy test in the office will be negative. So their urine pregnancy test will be positive at home, but obviously the one done in the office will be negative. So this is usually seen in women who have a very, very strong desire to become pregnant. It's also been suggested that the depression caused by this need is behind the occurrence of some hormonal changes that can mimic those of pregnancy. This is a form of conversion disorder. Its management does require psychiatric evaluation and treatment. So in these patients, they present to you like if they're pregnant. They might even have signs and symptoms of pregnancy, but ultrasound, however, reveals otherwise, and the office pregnancy test is negative. All right. Then there's another condition called pathological gambling. It's more common in males. It's defined as a persistent and maladaptive gambling behavior that usually is going to result in a preoccupation with gambling and arrangement for means to indulge in it. So these patients might gamble increasing amounts of money to achieve the desired excitement and can resort to illegal behavior to finance their activities. Attempts to reduce gambling behavior are typically unsuccessful, and they result in a jeopardized relationship and financial instability. When confronted about this issue, pathological gamblers are usually very dishonest and evasive towards those questions. So gambling can also be used as a means of escaping from problems or relieving unhappiness. So these are pretty straightforward, not too difficult. Now we're going to get into the psychotherapies. So there's different types of psychotherapies. There's interpersonal psychotherapy, supportive, psychodynamic, motivational, cognitive behavioral therapy. There's dialectical behavioral therapy and biofeedback. So let's go one by one. So interpersonal psychotherapy is, its duration is time limited. Typical patient will have relationship conflicts. They'll have life role transitions as well as grief. And their focus here is on the here and the now. There's current relationships and conflicts with interpersonal psychotherapy. The next one would be supportive psychotherapy. This would be something ongoing. This is a lifetime of treatment. A typical patient here has a lower functioning. They're in crisis. They can be psychotic, and they can be cognitively impaired. Supportive psychotherapy's focus is a therapist is used as the guide. It's to reinforce coping skills. It's to listen and foster understandings and build up an adaptive defense mechanism. So that's the key here, is to build up a defense mechanism for these patients undergoing supportive psychotherapy. Versus psychodynamic psychotherapy, this again is an ongoing duration. The typical patient is a higher functioning patient with persistent patterns of dysfunction, and they're a little bit more neurotic patients. So the focus here is on unconscious conflicts causing the symptoms. There's an exploration of past relationships and conflicts. They utilize transference and the breakdown of defense mechanisms. So in this, the difference between these two types of therapy, supportive and psychodynamic, remember that this would be, psychodynamic would be in a more higher functioning individual, where in supportive psychotherapy, there would be a lower functioning individual. And psychodynamic psychotherapy has to do with past relationships and conflicts. What has bothered you in the past? Did you have a problem with your mother? Did you have a problem with your father, husband, wife, things like that? So motivational interviewing is the next one. And this duration is variable because it's to deal with motivations. It's basically the typical patient for motivational interviewing is a substance use disorder patient. And the key here is to address ambivalence. It's to change. It's a non-judgmental focus. There's an enhancement of motivation to change, and there's an acknowledgement of resistance here. Next one is cognitive behavioral therapy, and this one's time limited. It's persistent. The typical patient is a persistent maladaptive thoughts, a patient that comes in with persistent thoughts that are bad. There's an avoidance behavior, or the ability to participate in homework would be one of them. The key focus here is to identify and challenge the maladaptive thoughts. It's also to change their behaviors, to change their emotions coming from those thoughts, and to focus on behavioral techniques such as breathing exercises, exposure, goal setting, visualization, eye on the prize kind of deal. That's cognitive behavioral therapy. And this is time limited. This isn't something ongoing like psychodynamic or supportive. Then you have biofeedback, which is also a variable duration. And the typical patient here is a patient with prominent physical responses that accompany psychiatric symptoms. And here the goal of treatment is to improve awareness and control over psychological reactions. It's also used to lower the stress levels and integrate mind and body techniques. And that would be the role of biofeedback. All right, so moving along, the next topic here is suicide. There's a suicide risk and protective factors. Some of the risk factors for suicide would be a pre-existing psychiatric disorder, feelings of hopelessness, impulsivity, previous suicide attempts or threats, a divorced or a separated couple, an elderly white man, unemployed or unskilled
patient, physical illness, a family history of suicide, family discord, access to firearms is a big one, and substance abuse. And then protective factors would be a social support, family connectedness. You want to actually promote this. Pregnancy, parenthood, religion and participation in religious activities. These are all things that help support and prevent suicide. So how would you assess suicide? So suicide assessment is basically on evaluation of three things: ideation, intent, and plan. So for ideation, it would be the wishing to die, not to wake up. This would be a passive assessment. Thoughts of killing themselves, that would be active. And frequency, duration, intensity, and controllability are also evaluated with ideation. For evaluating intent, the strength of the intent to attempt the suicide and the ability to control impulsivity, and also to determine how close the patient has come to acting on a plan. So if they've had any type of rehearsals or any type of failed attempts, those are evaluations of intent. And then evaluation of plans would be specific details on how they're going to do it: the method, the time, the place, access to the means like weapons and pills. Here we have weapons again. These are all high yield keywords. Preparations like gathering pills, changing one's will, and you'd also want to evaluate the lethality of the method. Is it a very lethal method that they're going to be choosing, or the likelihood of rescue? And then you always want to hospitalize these patients to maintain safety, and that's indicated for patients with active suicidal ideation that includes a plan and an intent to act. Patients with suicidal ideations but not specific plans or intent need intensive outpatient treatment, but not necessarily hospitalization if they're just sloppy about it. But remember, key thing here for the exam is suicide is a big topic, and if you see any type of suicidal ideation and hospitalized as part of the option choices, I would always put hospitalization. So I have rarely, if ever, seen intensive outpatient treatment as an answer choice. Okay. Now you want to assess and manage suicidality. So the assessment is a mnemonic called SAD persons. SAD person stands for sex, age, depression, previous attempts, ETOH, which means alcohol or other substance use, also rational thought loss like psychosis, a social support or a lack of social support, an organized plan, if there's no spouse or significant other, or a sickness or an injury. These are all the mnemonics for SAD persons. And how would you manage this? So for a high imminent risk patient, meaning a patient who has ideation or an intent and a plan, you want to first ensure their safety. Hospitalize immediately. You want to hospitalize involuntarily if necessary. Like I said before, you want to remove the personal belongings and objects in a room that can harm themselves, so they have any kind of access to guns. This doesn't mean putting locks on them or putting them in a safe. No, just remove them outside of any reach that they can be in. So out of the house, number one. Also, constant observation and security need to be required to hold against their will. How would you manage high non-imminent risk of ideation or intent? This would be if they have no plan to act in the future. You want to just treat the modifiable risk factors like underlying depression or psychosis, or if they're under the influence of any kind of substance abuse. You also want to go ahead and recruit family members or friends as a support for the patient. And you also want to reduce access to potential means such as firearms and medication. And there you have your firearms again. Can't stress enough how important removing firearms in hospitalization for suicide is. All right, next topic would be firearm injury. So for a firearm injury, the risk factors would be a male adolescent. There's behaviors of psychiatric problems, an impulsive patient, a violent patient, or some patient with a history of criminal behavior, and also low socioeconomic status. How would you prevent a firearm injury? Easy. You want to remove all the firearms from the house. That's not rocket science there. You want to store the firearms unloaded, and you want to lock firearms and ammunitions in separate containers, but on the exam, remove all firearms from the house is always the correct answer. Now, what are some of the homicide risk factors? A young male, an unemployed person, if they have access to firearms, substance abuse, antisocial personality disorder, or a history of violence or criminality, as well as history of child abuse and impulsivity. Okay, so now we're going to go into the topic of personality disorders, which is very fun. And it could be a little bit confusing, but we're going to try to set this straight here. So here we go. All right, so some of the key features here on the DSM-5 for the personality disorders would be paranoid. And this is a suspicious or distrustful person that's hypervigilant. So paranoid is a very hypervigilant person. Versus a schizoid patient, this presents as a loner, someone who is detached and unemotional. Schizotypal would be somebody who has odd thoughts, they're eccentric, they have perceptions and behaviors that are odd. There's a old mnemonic that says, dressed like a pickle is someone who's schizotypal. So dressed like a pickle would be someone who's odd, eccentric, weird behaviors. Okay. Antisocial is any person who has total disregard and violation to the rights of others. You have borderline, which is somebody who has chaotic relationships, sensitivity to abandonment, a labile mood, impulsivity, and inner emptiness with self-harm as part of their characteristics. Next one would be histrionic. This is your typical dramatic person. They're superficial, attention-seeking. You'll probably have a very dramatic woman as part of your vignette. Somebody who's wearing very exotic clothing or something, and they're very superficial, always attending to themselves in the mirror or something. This is your histrionic. Versus narcissistic, which is somebody who has grandiosity about themselves with lack of empathy. So don't get those two confused. What you would think narcissistic is normally, or what I would think, is actually a histrionic person. A narcissistic would be somebody who is completely into themselves in terms of grandiosity, and lack of empathy is a big one. You have an avoidant person, and avoidance is obviously one who avoids due to fear of criticism and rejection. They might give you a situation where they mess you up. They have their job requires them to give a presentation or something, and they're trying to avoid going there, and you're thinking it's because of a situation, and it's not the situation, is that they really are avoiding the whole interaction just due to fear of criticism and rejection. So keep an eye out on those little details. Dependent is somebody who's very clingy. They needs to be taken care of. Submissive, usually it's somebody who is in an abusive relationship and just can't leave the other person because they just need to be with them. That's dependent. And then you have obsessive compulsive behavior, and this would be a perfectionist, someone who's controlling or very rigid. All right, so moving on with antisocial personality disorders, Clinical features would be someone who violates the rights of others, social norms and laws. They're impulsive, they're irritable, they're very aggressive. They fight a lot. They are accused of assault. They're consistently irresponsible. They lie, and they're very deceitful. There's lack of any type of remorse. They don't feel bad about anything they do. And here the key thing is age is greater than 18 years of age. So this is an adult. So
In a minor, less than 18 years of age, it's not antisocial personality disorder. It's a conduct disorder. Okay, so management here. How would you manage antisocial personality disorder is with psychotherapy. You always want to try psychotherapy first if they're mild. So you just want to monitor or manipulate them with some type of therapeutic techniques, such as therapeutic relationships. And you also want to treat any kind of comorbid psychiatric disorders that they might have, such as substance abuse or depression, if that's also found in them. But I think that they might that's too conflicting and too many details for the exam. So just say that somebody who just likes to hurt other people for no particular reason, violate the laws, and if they're an adult, that's antisocial personality disorder. If they're a minor, it's conduct disorder. So basically, again, it's failure to sustain consistent employment, self-appraisal, and a very irresponsible work behavior. I think you get the picture. Next would be borderline personality disorder. In borderline personality disorder, the diagnostic criteria would require pervasive patterns of unstable relationships, a self-image, and effects of marked impulsivity, with more than 5 of the following features. So they have frantic efforts to avoid abandonment. There's unstable and intense interpersonal relationships, markedly and persistently unstable self-image, as well as impulsivity in more than 2 areas that are potentially self-damaging. There's recurrent suicidal behaviors or threats of self-mutilation, like cutting. And there's affective instability, like a marked mood reactivity, chronic feelings of emptiness and inappropriateness and intense anger. There's a transient stress-related paranoia or disassociation with borderline. So how would you treat borderline personality disorders? This would be, primary treatment is going to be psychotherapy.
And the types of psychotherapy are several types, can be effective, such as dialectical behavioral therapy that tends to be the best one. There's an adjunctive pharmacotherapy also with psychotherapy to target mood instability and transient psychosis. So in other words, you want to combine psychotherapy with second generation antipsychotics and with mood stabilizers, and then antidepressants if there's any type of comorbid mood or anxiety disorders. Now you have acute drug toxicities. So this is another highly tested topic, is pharmacology in psychiatry. So let's start with all the substance abuse drug toxicity. So first of all, we have PCP, or phencyclidine. It's a hallucinogen that patients present with a violent behavior. There's disassociation, hallucinations, amnesia. There's vertical or horizontal nystagmus, as well as ataxia. And high doses can actually cause severe hypertension. So you'll see very severe hypertension in these people, seizures and life-threatening hyperthermia with benzos, and that's used for severe psychomotor agitation. So just a crazy person that comes into the ER, starts flipping over gurneys and just causing mild hysteria, and they just have BPs sky high, and they're just very, very violent. You're thinking PCP. And first of all, you just want to give them a benzodiazepine to just calm their psychomotor agitation down. Next would be LSD. This is another hallucinogen. It causes visual hallucinations, euphoria, dysphoria, and panic attacks, as well as tachycardia and hypertension. But the visual hallucinations is going to be the one for LSD. I think we all know that. Next one is cocaine. That's a stimulant, which causes euphoria, agitation. But the big one here would be seizures and chest pain. Chest pain particularly, as well as tachycardia, hypertension, and mydriasis. Now, this can cause bradycardia or low blood pressure, as well as anxiety and psychosis,
They can have sweating, nausea, and vomiting, and an overdose can actually cause an MI and cardiac arrhythmia, seizure, or a stroke in these patients. So if you're seeing a patient that has signs and symptoms of an MI, but also has some type of euphoria or agitation involved, and they're a businessman, usually in their 20s or 30s, think of cocaine. Okay, methamphetamines is a stimulant, and this is associated with violent behaviors and psychosis. They also have diaphoresis, tachycardia, hypertension, and they also have coriform movements of their hands and fingers, as well as tooth decay. Next one would be marijuana, or tetrahydrocannabis, or cannabis, or cannabis, and this is a psychoactive drug. It causes increase in appetite, euphoria, dysphoria with panics, impaired time perception, a dry mouth, and conjunctival injection. That's pretty easy to figure out. You'll see somebody in their teens come in, and they come in with euphoria, dry mouth. They just look very low, and they'll have a conjunctival injection, and that's the key. Heroin is the last one, and that's an opioid, again causing euphoria, but this time heroin's associated with a depressed mental status. It's associated with meiosis, respiratory depression, and constipation. Since it's an opiate, it's going to cause respiratory depression and constipation. Okay, then you have inhalants. So inhalants abuse is commonly abused. Some of the inhalants that are commonly abused would be glues, nitrous oxide, or whippets is what they call them, amyl nitrate, which are called poppers, and spray paints. There's a way of abuse such as sniffing or huffing, which is an inhaled form when they inhaled from a very saturated cloth. Bagging over the mouth or nose, very, very weird, but that's what it is. Signs of an acute intoxication: you're going to have brief, transient euphoria, loss of consciousness. There's loss of consciousness that varies depending on a specific chemical inhaled. These are highly lipid soluble agents that produce immediate effects, and since it's lipid soluble, it lasts up to 15 to 45 minutes, and it's rapidly eliminated from the body. It's also not commonly included in toxicology screens, so they might present you with a negative toxicology screen, or you won't even do one because it's pretty obvious what they did. They act as CNS depressants and can cause death. There's dermatitis associated with glue sniffer's rash, and that's due to a chemical exposure around the mouth and the nostrils. Their liver function tests can be elevated, so look for that in the vignette, as well as boys around the age of 14 to 17. Those are the ones that are at the highest risk, and they can go unnoticed as common household products are used. All right, the next topic is amphetamine intoxication, and these commonly exhibit agitation, irritability, paranoia, and delirium. Other symptoms would be chest pains and palpitations, as well as tachycardia, hypertension, diaphoresis, and mydriasis. Other complications such as cardiac arrhythmias, seizures, hyperthermia, and intracerebral hemorrhages are also found. Diagnosis is based clinically as well as laboratory tests, and it's beyond the qualitative toxicology screen. And these are of limited utility. So one big one, or a new one, would be bath salt amphetamine intoxication. Bath salts are an amphetamine analog that can cause severe agitation and combativeness. So they can present with hyperthermia as well as psychosis, and the hyperthermia is due to the physical exertion, but it's not as severe as other types of psychosis like PCP intoxication. So this one is going to be kind of different from PCP. and we'll see why. So in bath salts, these are synthetic catathions, which consists of a large family of amphetamine analogs. So their mechanism of action is that they increase the release or they inhibit the reuptake of norepinephrine and dopamine, as well as serotonin, and they can cause myoclonus, and rarely they can cause seizures. But the most distinguishing feature of bath salts intoxication is going to be prolonged duration of effect. These patients have delirium and psychosis that lasts days to weeks, whereas the effects of intoxication with other amphetamines like PCP are very short duration. So that's a good way of remembering the differences. Bath salts are going to take longer. PCP is going to be short duration. Bath salts are usually sold as a white powder in small packages labeled as plant food, as cleaners or other substances, and may be ingested orally. They could be inhaled or injected. And it's not related to any products like Epsom salts or other substances that are used in bathing. Routine toxicology screens do not test for bath salts, unfortunately. So here you're going to have to just see the effects of the drug used. Okay, next drug would be MDMA, ecstasy, or something called Molly. This is it's called 3,4-methyl N-deoxymethylamphetamines, or MDMA. It's a synthetic amphetamine with a mild hallucinogenic property. There's increased synaptic norepinephrine and dopamine, as well as serotonin concentrations. It can lead to neurotoxicity with long-term use. MDMA is often used by college students during raves and large dance parties to enhance euphoria and also to increase sociability, to increase empathy and sexual desire, but they don't have any type of combative behavior. The intoxication here can lead to a form of hypertension, tachycardia. They can present with hyperthermia and serotonin syndrome, which we can remember as an autonomic dysregulation causing high fever, altered mental status, a neuromuscular irritability, and seizures. And here they can cause hyponatremia and death. There's a combination of MDMA with other serotonergic drugs, such as serotonergic antidepressants. They can increase the risk of serotonin syndrome, but it's not detected, again, by routine toxicology screens. With these patients, just remember somebody who went to a party and they're presenting with some signs of serotonin syndrome, but they're also extremely hyperthermic and very thirsty. Very, very thirsty. So that is the behavioral pattern that you should look out for on the vignettes. Next topic is your marijuana intoxication. It's pretty easy. Again, cognitive effects that include slow reaction time and coordination. There's impaired short-term memory, poor concentration. Some patients experience dysphoria. They have anxiety, paranoia. They have perceptual disturbances like auditory or visual hallucinations can also occur. But remember, these patients aren't psychotic. They're just under the influence of marijuana. There's also a psychomotor impairment that lasts beyond the time frame of euphoria and can persist for up to a day. And that can result in a high risk of injury or death in motor vehicle accidents. And chronic abuse is also associated with gynecomastia in men. So that's a good way of stopping to use the drug. Withdrawal syndromes. So we're going to talk about now the common withdrawal syndromes associated with substances. So let's start off by alcohol. Withdrawal symptoms of alcohol would give you tremors, agitation, anxiety, delirium, or delirium tremens is what it's called, as well as psychosis. And their examination findings are seizures. They can present with seizures, tachycardia, and palpitations. As well as benzodiazepines can also have seizures, tachycardia, and palpitations. But here their symptoms are going to be actual perceptual disturbances and insomnia. You can also add the tremors, agitation, and anxiety and psychosis seen with alcohol withdrawal, but the insomnia would also be part of a benzo withdrawal. For heroin withdrawal, they present with nausea, vomiting, abdominal cramping with muscle aches. They're also, on exam, you'll see dilated pupils, so you'll see mydriasis, yawning, piloerection, lacrimation. There's hyperactive bowel sounds, and that's pretty much it. Now with stimulants like cocaine and amphetamines, their symptoms are increase in appetite, hypersomnia, intense psychomotor retardation, and severe depressions, like a symptom of crashing. That's what their withdrawal symptoms would be. There's no significant findings on exam. It's just basically the symptoms. As well as nicotine, there's no significant findings, but their withdrawal symptoms would be dysphoria, an irritability state, anxiety, and increased in appetite, because nicotine is an appetite suppressant. All right, so alcohol withdrawal syndrome. So this can be subclassified with mild withdrawal, seizures, alcoholic hallucinosis, and other and delirium tremens. So basically a mild withdrawal, their symptoms would be just anxiety, insomnia. They can have tremors, diaphoresis, palpitations. They can have intact orientation. And usually that's basically within 6 to 24 hours since their last drink. That's a mild withdrawal. Versus seizures. Seizures are basically going to occur within a time frame of 12 to 48 hours of withdrawal. Seizures can be single, they can be multiple, and they're generalized tonic-clonic seizures. Versus alcoholic hallucinosis is when you actually see visual, auditory, or tactile hallucinations, as well as but they do have intact orientations and their vital signs are stable. And again, this happens between 12 to 48 hours, but it usually develops between 24 hours and resolves at 48 hours. So at past 2 days, they're going to be fine. But the most complicated one would be delirium tremens, which is a patient that presents with confusion, agitation, fever, tachycardia, hypertension, diaphoresis, and hallucinations. And this is going to happen 48 to 96 hours of withdrawal. Typically, it peaks during the second day following the cessation of alcohol. In any hospitalized patients with a suspected history of alcoholism, there's going to be precautions taken to prevent symptoms of withdrawal. But due to the serious potential complications of alcohol withdrawal, those patients should be placed on proactive treatment or protective treatment and be treated with benzodiazepines, which are basically CNS depressants that will limit the effects of alcohol withdrawal. There's chlordioxyperoxide, which is called Librium. That's a benzodiazepine, and that's the most common choice of treatment for alcohol withdrawal symptoms. So if you see a patient that has any type of alcohol withdrawal and they're just asking you, what would you give them as a treatment? Always it's a benzodiazepine. So what are some of the managements of alcohol withdrawal seizures? First, you want to rule out other possible causes of seizures, because you just don't want to blame it on the alcohol. You want to check for infections, you want to check for hypoxia, bleeding, metabolic derangements, persistent seizure disorders or pre-existing seizure disorders, or any type of confirmed seizures that was happening beforehand. Then you want to treat with a benzo, especially intermediate benzos such as IV lorazepam. That's going to be the preferred in-hospital setting to control the symptoms and prevent the progression to delirium tremens. And it's also safe in possible liver disease, so that's a big one. Alcoholics do tend to have liver problems, so this lorazepam would be safer in these patients because there's no active metabolites with lorazepam. Versus chlordioxyperoxide, this is very long acting and it's not preferred in the hospital setting in the patients with possible liver disease because of their metabolic side effects and their metabolites. Then you have adjunctive therapy that you give with the benzo. Like, you're obviously going to give them IV fluids. You're going to frequently monitor their vitals. You're going to give them thiamine, folate, and nutritional support. You can also give them phenobarbital, which can be used as an adjunct to the benzo if they have any type of refractory alcohol withdrawal and withdrawal to related seizures. Then we have heroin withdrawal. Now, heroin withdrawal presents 6 to 12 hours and it peaks 36 to 72 hours, and it could continue on for several days. It's very distressing, but however, it's not life-threatening. This is a big one. They present with restlessness, elevated pulse, and blood pressure, although it's usually not as elevated as alcohol withdrawal. So it's interesting because it's actually more lethal. You can actually die from alcohol withdrawal, but you cannot die from heroin withdrawal, although heroin withdrawal would probably be way more painful, and obviously that's important to treat the pain, but heroin withdrawal is not life-threatening. Then there's neonatal abstinence syndrome, which is neonates frequently exposed to heroin and methadone, such as from the mother. Methadone is given to heroin addicts and mothers to prevent uncontrollable withdrawal in infants. And heroin does not cause dysmorphic facies, but can cause intrauterine growth restriction. So that's a very important one, as well as macrocephaly, sudden infant death syndrome, and neonatal abstinence syndrome. Signs of neonatal abstinence syndrome would be irritability, a high-pitched cry, poor sleeping, tremors, seizures, sweating, sneezing, tachypnias, poor feeding, vomiting, and diarrhea. And they usually present within 48 hours after birth for heroin withdrawal. And that happens between 48 to 72 hours for the methadone withdrawal. It can be delayed up to 4 weeks. And treatment for neonatal abstinence syndrome includes symptomatic care to calm the infant down and help the infant go to sleep. You want to, such as swaddling, and provide small frequent meals to the infant. You want to keep the infant in a very low stimulated environment. Pharmacological treatment should be used only when supportive treatment does not control the infant's withdrawal symptoms. Remember, always try first supportive treatment. Cheap is best on the boards. Then you can move on to pharmacological treatments. And morphine finally can be administered and systemically weaned off to help control the opiate withdrawal symptoms. Also another type of withdrawal symptoms would be smoking cessation. In addition to counseling, several medications are going to be used to promote the short and long term of quit smoking. Bupropion is going to be the most commonly used. It's modestly effective. It has an increasing quit rate, so that's really good. It's always going to be the answer if you have a patient who wants to stop smoking. What kind of treatment you want to give them? Bupropion is a good one. TCAs are also moderately effective, but they're not approved for this. There's also varenicline, which is a partial agonist of the nicotinic acetylcholine receptor. And that's more effective than bupropion at increasing short and long-term quitting. And there's efficacy of all medications to enhance the nicotine replacement therapy in appropriate patients. Next, some of the steroids like glucocorticoids can induce manic or depressive psychotic episodes. If a child or adolescent is going to present with recent changes in behavior, emotions, and a social circle, then you want to suspect a substance abuse, even if the patient denies it. You want to perform urine toxicology screens, but keep in mind that the patient may be using a substance that's not detected on urine or routine toxicology screens. So bath salts, as we said, K2 is another one, salvia and household inhalants, all those are not routinely they're not done, and they're not very detectable on toxicology screens. So here you have to actually go on see the symptoms of the patient. In addition to substance use, other considerations of adolescent patients presenting with behavioral changes are going to include the partners, if they are violent, date rapes, physical or sexual abuse, and finally pregnancy. And that is the